that it's very difficult for me. This is the first time in the last 30 years that I have been able to do this with the help of slides. Thank you very much.
Thank you, Dr. Kapadia. Let's give him a big hand once again. Thank you so much, sir. Because he took so many, questions and queries yesterday, so we are not taking it today, and we are moving over to the next speaker, Dr. Stephen Neeson, please. Welcome, Dr. Stephen Neeson. He was here yesterday, and as I mentioned yesterday, in this conference, we are so lucky to have not one, but 3 experts from Cleveland Clinic. Dr. Tuju was yesterday, of course, Samir Bhai Kapadia is there. So 3 experts from Cleveland, which is considered as the Mecca of cardiology. And today's topic is post-STEMI management and update. He was introduced yesterday, but for the benefit of all, I'll introduce once again to the benefit of people who have come today. Dr. Neeson is the Director, Joseph J. Jacob Center for Thrombosis and Vascular Biology at Cleveland Clinic, USA. Besides this, he's wearing various hats, having leadership positions in other departments. And he is listed amongst the top 100 most influential people, scientists and thinkers at Time magazine. He's been awarded the Golden Achievement for Medicine at the 20th Golden Age Kenters of Greater Cleveland. He's been associated with the US Department of Health and Human Services. And he's the Editor-in-Chief Catheterization and Cardiovascular Intervention Self-Assessment Program at the American College of Cardiology. And he's on the editorial board of International Journal of Cardiac Imaging and many other journals. And he has authored various books, chapters, and manuscripts. Welcome, Dr. Neeson, and I request the volunteers to welcome him in the traditional Vidyapit style. Please.
Well, first of all, let me thank all of you for the wonderful hospitality that I've been shown coming to India. And I also, it's a pleasure really to follow the 2 talks about non-pharmacological approaches to cardiovascular disease. And I agree with many of the conclusions that, we focus a lot on pharmacology. And I've been asked to talk about pharmacology, but we can't neglect these other things. This slide also has my disclosures. I do not accept any honoraria or any other fees from industry so that I can be completely independent. So the question I was asked to address is how do we deal with the problem of residual risk? Statins are phenomenal. They've made an enormous difference, but they only reduce heart disease by about 1/3. And the question is, what do we do about the 2/3 of patients in whom statins fail to prevent the disease? And I have listed some of the potential approaches, and I'm going to talk about 3 of them. HDL raising, further LDL lowering, and triglyceride reduction. This was the topic that I was asked to address. Now, let's talk about HDL. We have been on a quest for many decades to find a way to raise HDL pharmacologically. And the reason is that the epidemiology is very clear, that both LDL and HDL in epidemiological studies are strongly associated with outcome. And so it made very good sense that we should try to raise HDL with drugs. And we've tried, and we've tried, and we failed, and we failed over and over again. Let's talk about niacin. A decade or two ago, many of us administered niacin to patients to raise HDL. And this comes from the AIM-HIGH trial that was sponsored by the National Institute of Health. Niacin was given and compared to placebo, and there was absolutely no benefit. HDL did go up modestly, but there was no reduction in morbidity or mortality compared with placebo. A second trial performed with the combination of niacin and an agent, laropiprant, designed to reduce flushing from niacin. Absolutely no benefit whatsoever. And so niacin has been abandoned, and even more troubling is that if you actually look at the adverse events with niacin, they all go in the wrong direction. Worse GI, increase in infections, increase in bleeding, worsening diabetes control. These are all statistically significant harms from niacin. So there is really net harm from niacin, not net benefit. So we turned our attention to cholesterol ester transfer protein, which is involved in shuttling cholesterol ester between HDL and LDL. And if you block this enzyme, HDL goes up, and it goes up a lot. And we were really excited when the first of these drugs was developed, and we worked on nearly all of them in our group. There were 4 developed: torcetrapib, dalcetrapib, anacetrapib, and evacetrapib. The first one, and we did one of the early studies published in the New England Journal of Medicine with this drug, torcetrapib, which was compared, the combination of torcetrapib and atorvastatin was compared to atorvastatin alone, and we saw a nearly 61% increase in HDL. And so we were very confident that this increase in HDL would reduce morbidity and mortality. But in fact, in the large outcome trial, authored by my friend Phil Barter from Australia, the hazard ratio went in the wrong direction. There was a 25% higher rate of major adverse cardiovascular events with torcetrapib compared with atorvastatin alone. Very disappointing. And in fact, there was a 58% higher risk of mortality. And so this really stunned all of us who believed at the time that HDL raising would work. Now, the reasons are unclear, but one of the things that we saw in our study, which was an intravascular ultrasound study of torcetrapib, was an increase in blood pressure of 4.6 millimeters of mercury. And clearly raising blood pressure is not a good thing to do given the relationship of hypertension to outcomes. So we said, well, maybe torcetrapib failed because it had this adverse effect of raising blood pressure. And so along came dalcetrapib, the second of the drugs to be tested. This drug didn't raise blood pressure, but it didn't work either. The hazard ratio is 1.04. There's no evidence of a statistically significant benefit. The HDL raising was modest, 30 or 40%, but a lot more than niacin, and no beneficial effects whatsoever. We studied in a trial that was organized by our group at the Cleveland Clinic a drug called evacetrapib. And evacetrapib was even more effective. It raised HDL by 130%, and the average HDL in our trial reached 104 milligrams per deciliter. We thought this would surely result in a benefit. But in fact, the hazard ratio was 1.01, completely neutral, no benefit p-value 0.85. It was a big trial. It was 1,500 events, and we saw no benefit. And then finally, the fourth drug, anacetrapib. Long study going on for 5 years of this drug, and it did show a very small benefit that occurred after about 2 to 3 years, about 9%. But one of the things I didn't show you is that all of these drugs, with the exception of dalcetrapib, lower LDL cholesterol. They don't just raise HDL. And so, in fact, if you analyze the results of the anacetrapib trial, what you see is that this very slight benefit was entirely consistent with the modest LDL lowering effect of anacetrapib. So that it appeared that raising HDL had absolutely no benefit whatsoever. And so we've learned a terribly difficult lesson that this strategy for raising HDL just doesn't work. So we tried other strategies. We thought that if we could intravenously infuse HDL, either synthetically or naturally occurring HDL, that we could, in fact, produce benefits for patients. Now, we did a pilot study about 15 years ago with a variant form called ApoA1 Milano, but we've also, in more recent years, studied other ways of administering HDL intravenously. This is from our original study published in JAMA in 2003, a long time ago, 15 years plus ago. And it looked like it was working. But a lot of these patients weren't on statins. It was a very old trial. It was very small. And we weren't certain whether this would actually hold up in the modern era. And the answer is that it didn't. When we repeated the experiment a year or two ago, we published this recently in JAMA. What you see is the placebo patients actually did better than those that were infused with this synthetic HDL. And it's important in medicine, and for the some of the young people here, don't be discouraged when you get a negative result. A negative result of a trial is every bit as important as a positive result. Publish it quickly, and tell people what doesn't work, just as we tell them what does work. And it just didn't work, and we told people that. There was a second product that we studied in parallel, and without getting into this, this is the Serenus HDL mimetic. Same thing happened. If anything, the placebo group did better than the group that got infused with HDL. Terribly discouraging, and it really showed us that even infusing HDL didn't reduce cardiovascular morbidity or mortality. Now, there's one more drug still in development. It's an Australian company. It's called CSL112. They're continuing their trial, but I'm not optimistic. We've had 6 failures, 4 CETP inhibitors, 2 HDL infusions, plus 2 failed trials of niacin. I am sorry to tell you this. It is time to give up on HDL. It's a marker for disease, but it's not a target. Now, interestingly enough, raising HDL with the approaches that we heard about from Professor Manchada and from Dr. Kapadia may make a difference. Exercise raises HDL, and I think there's some data in some of these other lifestyle changes, and that may well work, but drugs don't work. Well, what about triglycerides? You know, triglycerides, have had this strange relationship over the years where, it was important, then it was not important, and a lot of argument about triglycerides. I'm going to tell you what I think about triglycerides as a target to address residual risk. Now, this is a huge problem, I am aware, in India. That with just a little bit of abdominal obesity, South Asians get this metabolic syndrome with very high triglycerides, related to small increases in body weight. And we know from a variety of studies, these are US studies, that triglycerides, the relative risk of coronary disease is about as strong with elevated triglycerides as it is with elevated LDL. So the epidemiological data suggests that triglycerides are a valid target. And we have genetic data. So these are data, 2 genetic variants that are associated with lifelong reductions in triglyceride. And sure enough, those people that have low triglycerides for life on a genetic basis have a very substantially reduced incidence of early onset myocardial infarction. What we think is going on here is that there is a common pathway to hypertriglyceridemia that involves insulin resistance, which occurs with abdominal obesity. And these are all the things that happen with insulin resistance, but amongst them are high triglycerides and a more atherogenic, small, dense LDL that appears to have a greater likelihood of uptake by the arterial wall. Well, is there evidence that lowering triglycerides pharmacologically might work? An older fibrate, gemfibrozil, I don't think it's used anymore. It's certainly not used much in the United States. It may be used some in India, I'm not sure. Lowered triglycerides by 31% in the VA HIT trial, now published nearly 20 years ago. And in VA HIT, with the triglyceride reduction produced by gemfibrozil, non-fatal MI and CHD death went down, non-fatal MI went down, stroke went down. All the cardiovascular endpoints had a 20 or 25% improvement. So it is clearly promising data, not contemporary, not modern data in the statin era, but this is now in the pre-statin era when not a lot of these patients were actually on statins. Fenofibrate, the fibrate that most of us now use, was studied carefully in the ACCORD trial, and there was no benefit. And these were now patients that were being treated with statins. And so many of us said, well, maybe fibrates don't work if you give them to people who are already been treated with a statin drug. But what I want you to see here is that there is, and one always has to be careful about subgroup analyses because they can really be misleading. But in this study, if you look at in the box at the bottom there, that those that had elevated triglycerides and a low HDL, there was a benefit of fenofibrate. The problem with the ACCORD trial is they gave fenofibrate to everybody, not just people with high triglycerides and a low HDL, and it didn't work. But in the group that most of us would agree we would want to consider treating, it did work. This is now a meta-analysis. 5 trials of fibrates shown here, and at the top in blue, you see patients that had both high triglycerides and a low HDL. And there's a 29% reduction in major cardiovascular events. In people that had neither high triglycerides nor a low HDL, no benefit. And so we think that one of the issues with these drugs is they have to be used in the right people. We have been interested in using omega-3 fatty acids. And it's a complicated story, and I'll try to summarize very briefly. But there is a trial recently, just within the last few months, published in the New England Journal of Medicine called Reduce It, that used one of the omega-3 fatty acids, EPA, and seemed to show a 25% reduction in adverse cardiovascular outcomes. But it's a very difficult trial to interpret because the control agent that was used, the placebo, was mineral oil, and we know that mineral oil interferes with the absorption of statins. And so we're concerned that this benefit was due to toxicity of the placebo rather than the benefits of the EPA. We are running a trial called the STRENGTH trial. This is in people with high triglycerides, low HDL. We have 13,027 patients enrolled. We're in the advanced stages of follow-up. We're about 1 year from completion of this trial. And it's using a derivative of fish oil, omega-3 carboxylic acids plus a statin versus a statin alone. Now, let me tell you that we are reasonably confident that this will be a good test of whether or not the strategy of triglyceride lowering is going to work. I could end up eating my words, but I will predict for you a positive trial. So watch in a year or so from now in the New England Journal. We'll be ready to publish, and we'll tell you. And if it's negative, we'll tell you that too. But we hope it's going to be positive. Now, finally, let me just say that the idea of lowering LDL further is certainly a strategy for which there is very little doubt that it works. We have decades now of data. This is all a whole bunch of secondary prevention trials. And you look at LDL on the horizontal axis and the event rate on the vertical axis, and they line up along a straight line. Every incremental reduction in LDL cholesterol seems to reduce the coronary heart disease event rate. In fact, in the statin trials, where 2 statins were compared, one of them more potent than the other. So this is, high intensity statin versus moderate statin. There's a 28% reduction in major adverse cardiovascular events in this meta-analysis of now 5 separate large-scale statin trials. And so I think that's a pretty clear set of evidence. What's fascinating about the data is that a 1 millimole, 39 milligram per deciliter reduction in LDL had the same effect if you started at 135 as you saw if you started at below 78. That same delta, that same difference, has the same benefit of 22% across the entire spectrum of LDL levels, which suggests that there is no threshold for benefit. And that's why I've struggled with the guideline writers who have seemed to not quite get this. We have done a series, and we've now done 12 intravascular ultrasound trials, and we looked at all of the LDL levels in these trials. And there are very few things in medicine that line up along a straight line, but this one does. As you lower LDL, when you get to about 65 milligrams per deciliter, you start to see disease progression reach 0. And when you go below 65 milligrams per deciliter, you start to see regression. And so if we can get LDLs down below 65 milligrams per deciliter, we think that many patients will have less disease at the end of a treatment interval than they had when they began. And so this is pretty strong evidence. Now, we tested this recently with even a more powerful LDL lowering therapy, a PCSK9 inhibitor. And I want you to see how far we went. We published this in JAMA in 2016. We started with an LDL of 93 with statin alone. Then statin plus a PCSK9 inhibitor, we got to 36.6 milligrams per deciliter. I never thought in my career I'd ever see such low LDLs in a clinical trial. Some of the people were in single digits, below 10. And what happened is in those people that got to 36.6 milligrams per deciliter, we saw massive regression. We saw much less plaque at the end of 18 months of treatment in the coronary, measured by intravascular ultrasound, than we had seen at baseline. And so this strategy was highly effective. When we graphed it, you see that that relationship extends all the way down to as low as 20 milligrams per deciliter. So we see, and we saw no harms at these very low LDL levels. And so we think you can't have too low an LDL level. And in fact, if you want to really regress disease, get people to really low levels. And then finally, recently, the Fourier trial and others have shown that similarly, if you look not just at disease progression, but at morbidity and mortality, that getting LDL down with a PCSK9 inhibitor and a statin to as low as 30 milligrams per deciliter, which is what they achieved in Fourier, was associated with a very substantial reduction in cardiovascular death, MI, stroke, and hospitalization for unstable angina or revascularization. And in fact, if you look at just the hard events, death, stroke, MI, there was a 20% reduction. This is at an LDL of 30 compared to 93. So let me finish with this, I hope, very clear message. Our idea of what a normal cholesterol is has been colored by the fact that our modern society doesn't have the best diet in the world. If you look at primitive populations, you know, Guatemalan Indians and natives of rural New Guinea, et cetera, you see that 50 to 70 milligrams per deciliter is the typical LDL. If you look at domestic mammals, it's even lower. If you look at newborn babies, it's about 30. If you look at wild mammals, we think that the LDL level for which our species is adapted is probably a lot lower than we traditionally see. And so what we used to say is you can't be too rich or too thin. We now say you can't be too rich, too thin, or have too low an LDL cholesterol. Let me leave you with that thought, and thank you for your attention.
Thank you very much, Dr. Nissen.
We'll take some questions.
Of course.
You can just sit here. Yeah.
Thank you so much, sir, for a very wonderful talk on cholesterol controversies. Now we are inviting you for the questions. Any questions?
Well, outstanding, Dr. Nissen, as expected. Just a question about HDL. There are two types of HDL now, functional and dysfunctional. And we know that there are certain studies to show that high HDL may be a risk factor. Did you have any idea of functional versus dysfunctional in these, by these? And so, the second question is, small dense LDL is a big problem for Indians with high triglycerides and all. Do you have any data on small dense LDL, which is responsible for disease in Indians? Thank you.
Well, those are two very, very good questions. I'm well aware of the research suggesting that the characteristics of the HDL make a difference. One of our colleagues at Cleveland Clinic, Stan Hazen's done some fine work with this. And some of these people with really high HDLs do, in fact, have some kind of a dysfunction in the HDL. But I think it's still too early. We don't have clinical trials. We can't quite get a complete grip on that. Now, the problem of small, dense LDL, if I had more time, I was going to go into that. But what's really interesting is you can predict very clearly who's going to have small, dense LDL. If their triglycerides are elevated, they have an increase in small, dense LDL. And so I think that this idea of triglycerides and small, dense LDL is probably a very important concept, and I recognize it's quite important in the Indian population.
Finally, the PCSK9 inhibitors, I'm a big fan of that. Yeah. But do you have any concern if the LDL goes very low, less than 20? You said single digits also. Yeah. Yeah. Can they get depression? There's some concern, depression or suicidal tendencies. You think it can occur?
So we've looked at it, and I didn't have time to show the data, but there was a trial called Ebbinghaus, which was part of the Fourier trial, where they looked at neurocognitive function at very low LDLs. And there's no adverse effects. And so I think LDL is a waste product. I think it has no functional value. And We have people in some of our trials. One of the trials we did called Asteroid, we looked at a group of people whose LDLs were less than 10, and they seemed entirely normal. So I'm not worried. I'm not worried about too low an LDL.
Thank you. Thank you.
Yeah.
Sir, what could be the best way of controlling the LDL, because it is the culprit?
I'm sorry, I didn't quite hear that.
Sir, my question is, what could be the best way of controlling the LDL?
Best way to control LDL. Yeah. Well, my view is that we also have to consider, I mean, I love the PCSK9 inhibitors too, but they're very costly. And I don't know what they cost in India, but I know they cost more than most people can afford in the United States. So what I will tend to do is use potent statins in the highest possible doses. If I am not low enough, add ezetimibe, which is generic and inexpensive. And then for the very high-risk patients, to consider a PCSK9 inhibitor. If PCSK9 inhibitors were inexpensive, we would use them in large numbers of people, but they're not. And so this is where economics, pharmacoeconomics clash with pharmacology. And I wish we could use these drugs in more people. But I think statins are great. Ezetimibe probably does some additional good, but the real problem is some of these people with heterozygous FH, we can't get their LDL down unless we add a PCSK9 inhibitor.
Any other questions?
You want to ask a question? Okay, go ahead.
Sir, does PCSK9 have any anti-inflammatory effect also? Because yesterday you said that we have to treat the inflammation part also.
Yeah. So, yesterday I showed you our data on the anti-inflammatory effects of statins, which are actually quite profound. What's remarkable is that the PCSK9 inhibitors do not have an anti-inflammatory effect. And so this is more evidence that statins are working by two pathways, by both LDL reduction and by anti-inflammatory effects, which I talked about yesterday, but it doesn't seem to happen with the PCSK9 inhibitors. No reduction in C-reactive protein, IL-6, or any of the other inflammatory markers. A bit surprising.
Dr. Nissen,
Yeah.
thank you very much. Out of all the people who have been helped most is myself, because with 80 milligram of atorvastatin, my LDL remains 66, which I am not happy. I want to reduce it further. So I added ezetimibe along with that. I'll see the result. But I would like you to impress upon all these people who are here. They are so much worried about, they are asking you how, that there is no way better than using atorvastatin to reduce LDL as much as possible. And dose of 80 milligram is not a high dose at all, as we used to believe it before. Yeah. When it comes from you, it will have a very, very salutary effect, because all your talk, I learned from everything down, from all the investigations. I am encouraged, because I try to keep the LDL cholesterol very low as much as possible in all my patients. But, and you have helped me as well. So thank you very much, because you really put an emphasis on a very, very simple thing, because as I told you, ultimately everything done, taking a pill is much easier than all the lectures that we can give. And atorvastatin is really a molecule of the century. And that's what I feel, and thank you very much.
Well, I agree with you, and I follow your pathway here. So I keep my LDL at about 50. And I want to be able to continue to work when I reach your age. But let me also say something, because I was asked to talk about pharmacology. I strongly agree with the perspective that you provided and Professor Manchada provided, that in fact there are these non-pharmacological interventions such as exercise, meditation, other things have to be combined with the pharmacology. You don't want to emphasize one over the other. You know, in America, everybody wants the answer to be in a pill because it's easy. You just take a pill once a day. But I think we have to do these other things, and we have to teach our patients that these other things are very, very important. Now, the final point I want to make is that 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin are very safe. Fear of statins is a disease in and of itself. And for the high-risk patient, don't fear statins. And for those of you that are interested, I wrote an editorial in the journal Annals of Internal Medicine about statin denial, people who deny the benefits of statins, which is in fact a really big problem in America. I think it may even be a problem here in India as well. And we can't fear these drugs. They have made, I agree with what you said, probably half of the benefits we've seen have come from these more effective therapies of LDL cholesterol.
May I add a small comment? For Indians, the dose of statins is much less.
Yeah.
Dr. Didwania, we have also done study, 40 milligram is as good as 80. We have done and reported this recently.
Good.
That for Indians, the dose is much. Dr. Didwania did it long back, that 5 milligrams is equal to 20 milligrams.
Yeah.
So I think the dose, high dose may be 40, not 80 for Indians. Large number of trials.
Yeah.
Thank you very much.
Yeah, if you get the LDL where you want it on 40 milligrams.
It's the same.
Yeah,
40 and 80. We did that report.
Yeah, I think, you know, we know that. It's also true, by the way, in some other countries, like in Japan, they use much lower doses. So different groups of people with different, you know, ethnic backgrounds are going to have a different response.
Not more questions. I want to thank Dr. Nissen for coming. It is just a great pleasure, great honor, and just a most wonderful thing for us to have him here. Thank you again, Dr. Nissen. And it will encourage a lot of young people to do research and to do such a meticulous work and publish it. So thank you again for coming.
And thank you for all your wonderful hospitality.
Ladies and gentlemen, we move ahead with the next presentation, and that will be a very interesting topic by Dr. Samir Kapadia. Basically, he's talking about the update of the management of the the period after the acute heart attack. So he's going to talk. And again, for the benefit of people who are not yesterday, I'll give a quick introduction about Dr. Samir Kapadia. He's a section head, invasive and interventional cardiology at the Cleveland Clinic. He is the director of the Stone's Cardiac Catheterization Laboratories Cleveland Clinic and the program director, interventional cardiology. So he is also wearing several hats, and he did his research fellowship in cell biology and molecular cardiology. And he's the member of the American College of Cardiology, American Heart Association, and Society of Vascular Medicine and Biology, and awarded from 2004 to 14 Top Doctors Cleveland Magazine, in 2013 Innovator Award, and 2012 the Innovator Award at Cleveland Clinic, and he's been on the editorial board of leading medical journals and principal investigator in numerous clinical trials, and he has published numerous books, chapters, and abstracts as a part of peer-reviewed publications. Welcome, Dr. Samir Kapadia, and I request the volunteers to again welcome in the traditional Vidyapith style, please.
Thank you, everybody, for coming. And as I thank Dr. Nissen, too, that it was such a great pleasure to have him here. What I'm going to talk about, after the heart attack, what should we do to improve the health? So some of this is a little technical, and some of this is not very technical. So the first part is to say this is just a summary of all the things that you should keep in mind. Evaluate the LV function, meaning that how good is your LV function. This is the most important determinant of what you are going to do next. And this you must keep in mind, that what is the LV function. And then there are risk factor management. So I'll talk very briefly specific to the subject of patients with post-MI patients, and then cardiac rehab, which are all extremely important elements of treating patients after surgery. So here, if you look at the patients who have ventricular arrhythmias or who are at risk of having ventricular arrhythmias, meaning that if the ejection fraction is less than 35%, the current guidelines are, if you have green, that means that there is a class 1 indication of needing ICD. So the defibrillator, expensive therapy, defibrillator is necessary if your ejection fraction is less than 35%, and if you are going to live longer, meaning that if you are going to just live one more year or very old and otherwise doing okay, then defibrillator may not be necessary. But if you are a young person and likely to live another 30 years, then a defibrillator saves life. That has been shown. So this is a useful therapy for these patients. Beta blockers, again, are helpful in the patients, especially if your ejection fraction is low, and it is called class 1 and with evidence B. What evidence B means is that there is no randomized trial, head-to-head comparison, people taking beta blockers or not. First 24 hours, they can be initiated and then continued, but if you are hypotensive, meaning your blood pressure is low, heart rate is low, then it is not absolutely necessary. ACE inhibitors, again, ACE inhibitors come in a lot of different names that you may know, lisinopril or enalapril or all other different medications that may be available in India. They all have class 1 indication, meaning that you should take an ACE inhibitor if you had a heart attack, if you can tolerate it. And if ACE inhibitors are not tolerated, then a ARB, similar medication to the ACE inhibitor, is again a class 1 indication. Now, the other question that is very commonly asked, and the answer is a little bit more difficult, is to say that how long should you continue the Plavix? So you are on aspirin, and then you take a medication called Plavix or clopidogrel, or ticagrelor, or prasugrel. So there are a lot of different kinds of antiplatelet agents, and you usually take aspirin plus one another antiplatelet agent. The current recommendation is that after the myocardial infarction, you're supposed to take it for 1 year. After 1 year, you have to decide whether the risk of bleeding, because when you take dual antiplatelet therapy, your risk of bleeding is higher. So if the risk of bleeding is higher and you want to stop the dual antiplatelet therapy or continue the dual antiplatelet therapy to prevent future heart attacks. So this is a balance that you are going to strike. And how do you strike this balance? So this is why there is a lot in the literature. There are a lot of different kinds of scores available, and the DAPT is one of those scores that lets you decide if you have a lot of risk factors for having heart attack, it is probably better to continue dual antiplatelet therapy. And most commonly we say that a clopidogrel is a better dual antiplatelet therapy than ticagrelor. And if you're going to take ticagrelor, you want to reduce the dose to 60 milligram twice a day rather than 90 milligram twice a day, along with aspirin. And aspirin in a low dose, which is 75 milligrams. I'll skip some of these things to say that the risk of bleeding is higher no matter how you cut it if you take dual antiplatelet therapy. If you want to stop the dual antiplatelet therapy, maybe it is beneficial to stop aspirin compared to clopidogrel. So if you want to take one or the other, some people would recommend, including myself, to take clopidogrel rather than aspirin, because in patients who had a heart attack in the past. So the duration is decided by clinical presentation, type of stents, and I didn't go in the details because type of stents, so many different types of stents are available, how we put the stents, how many stents we have put, all those things determine this, and other medications. So you are on any blood thinners, then also you have to decide whether you want to take an additional antiplatelet agent or not, and risk of bleeding and risk of thrombosis. This question then comes up is that, is there a role of Coumadin or warfarin in the patients with heart attack? And there, now, you know, if you have atrial fibrillation, irregular heartbeat, then of course you want to take anticoagulation. But for anterior wall MI, in the past we used to say that your EF is less than 30, you should take anticoagulation. This is no longer considered a class 1 indication and class 2B indication, especially if you're taking dual antiplatelet therapy, because the risk of bleeding is much higher. whether you are going to take a low dose of newer anticoagulants like rivaroxaban is another question that has been recently answered in a randomized trial, but that is 5 milligrams of rivaroxaban, which is not typically available, at least in the United States, and in here, it is not yet available in 5 milligram dose. So all other indications for anticoagulations are class 2A or 2B, as you see there. Now, risk factor management. So the blood pressure guidelines have recently changed. You may know this, that the blood pressure guidelines say that now the normal blood pressure is less than 120 and 80. So 120 to 29 and blood pressure is now considered as elevated blood pressure. And then stage 1 is 130 to 139, and stage 2 is more than 140. The guidelines would say that you have to do treatment to achieve the blood pressure after myocardial infarction less than 120 to 80. And there are several different interventions that this particular guideline suggests that are now proven. So proven non-pharmacological interventions, the most important one is weight loss. So 1 kilogram of weight loss reduces the blood pressure about 1 millimeters of mercury. So this is huge. So you want to make sure that, and there is also evidence to say that trying to lose weight is in itself a healthy behavior, and it reduces your risk of heart attack. So not that you are losing weight, but you are just very conscious to lose weight, in the sense that every time you eat, you feel guilty. That is a good behavior, to say that what you are eating is, you are evaluating it, and you are trying to say that I don't want to eat more even though I'm hungry. So this is a very healthy behavior, and it reduces your further future risk of having heart attack. Healthy diet, so there is a DASH. This is the diet that is to reduce the hypertension, and this is consuming fruits, vegetables. Dr. Manchandani elaborated on this yesterday, but it's very important. And even the nuts. So the nuts are supposed to be good, including the cashews, can also reduce your blood pressure, hypertension. Dietary sodium intake, less is better, also for atherosclerosis and for hypertension. And enhanced dietary proteins also reduce the blood pressure. Excuse me. The other important elements are exercise. So aerobic exercise, 90 to 150 minutes of walking per week. So that would say that if you walk 5 times a week, you may want to walk 30 minutes a day. So this is a aerobic exercise, dynamic resistance, and and isometric resistance. All of them are very important to reduce the blood pressure. And alcohol consumption, if you are consuming alcohol, then you want to reduce the alcohol or not take alcohol. So it is not to say that you start moderate alcohol. It is to say that if you are taking alcohol, at least be moderate and not take more alcohol. The guidelines would say that the hypertension control in the post-MI patients with stable angina, as I said, that you want to reach the blood pressure less than 130/80, preferably less than 120/80. And if you can achieve this by lifestyle modification, that is okay. But if you cannot, you may want to take beta blockers, ACE inhibitors, or ARBs, as I pointed out, some medications there. Diabetes. So the diabetes is, again, a super important part to maintaining health. And so if you look at the overweight and obese patients, so overweight and obese patients in the United States are considered BMI more than 31. For Indian population, that number is 23. So if you are going to have a BMI more than 21 or 23, I would consider Indian population obese. So if you are obese and if you reduce your weight, you decrease your rate of diabetes. So if you see this, this is the percent patients with diabetes were less if you reduce your weight. So simple thing, this is the Finnish diabetic study, very old study. And if you look at the metformin plus lifestyle medication or just metformin alone, to say that if you can decrease the pre-diabetic state to going to diabetes, no difference, meaning that lifestyle modification is as good as just taking metformin medication. So again, lifestyle modification is huge in terms of, and metformin does not work, basically, if you are doing good lifestyle modification. There's no additional risk. Gut obesity is a big deal. So people who don't look obese, but if you are using, so what I typically say that the belt size, if your belt size is more than 32, you are definitely obese if you are not more than 6 feet tall. So if you are less than 6 feet tall, you should not use 34, 36 size trousers. That means you are obese. And there is a metabolic syndrome in Indian population. This is not true for other population, but the gut obesity is extremely high, or implications of gut obesity in terms of increasing cardiac output, increasing cardiac mortality is tremendous if you are accumulating fat on your belly. Hyperlipidemia, we have stressed so many times that the LDL cholesterol level is the most important thing, and lower the better. There is no bottom number. There is no risk of dementia. There is no risk of losing memory. There is no risk of losing any of the other things that people are worried about. It actually does not happen. Muscle pain and some lack of energy in the muscles and things like that people complain is very, very similar with the placebo compared to statins. There are some patients who do have muscle-related issues, very, very few numbers, and the solution is not to stop statins, maybe PCSK9 inhibitors, or there are certain other methods to reduce the muscle-related side effects, but these side effects should not be the reason not to take statins. As I said, it is extremely rare. Most commonly, these side effects are not from statins, but even the placebo. So mentally, people thinking that they're taking the medication, they feel the pain. That is the most common way the pain happens. Threshold, as I said, is at least, the guidelines say that at least you should achieve 70, but in my opinion, again, the 70, as Dr. Nissen was pointing out, there's no reason for 70. So if you look at all the data, it goes up to 30s and 20s, and even 10s is safe, and so lower is better. So at least use high dose of statins, and whatever that high dose you consider as high dose. Stress reduction, and Dr. Manchandani also pointed out this type D personality. So what is a type D personality? Is a negativity. So if you have a negativity in yourself, that is worry, irritability, gloom, reticence, meaning that you are socially, you don't have the lack of self-assurance, you're not talking with people, you're not taking care of yourself, basically. So these are the people who have the highest chance of having future problems, cardiac problems, and group therapy, yoga, education, rehab, all of them are super important to control the stress with MI. Diet, again, Dr. mentioned that he gave a very elaborate talk on saying what is the diet, but again, fruits, vegetables, grains, and some form of protein, and that protein can be from the lentils, that protein can be from fish, or that protein can be from milk. Low fat, again, less than 1% is considered low fat milk. So either skim milk or low fat milk is the only milk that you should use. A lot of people consider 2% milk as a low fat, but that's not low fat. The regular fat milk compared to 4%, 2%. But it is not a low fat milk. And these are the typical recommendations from heart attack patients. So balance calorie intake and physical activity. Consume diet rich in fruits and vegetables. And again, when we say vegetables, not fried vegetables, not overcooked vegetables. We are talking about vegetables that are cooked with minimal oil or without oil and boiled, and potatoes in particular are not considered vegetables in the sense that they're very high in carbs. So simple carbs are not the vegetables. Consume whole grain, not the maida, but the real whole grain flour is the one that you should consume, because otherwise your insulin level goes up as soon as you eat the refined grains. If you are having meat, then lean meat, as I said, fat-free milk, and then the oils, again, Dr. Manchandani mentioned that maybe the canola oil or the mustard oil may be the best oil for the Indian subcontinent, and little or no salt. If you look at the physical activity, lot of trials, lot of data, but I just put one of them, that low physical fitness is associated with increased mortality. But look at the number. The number is the death rate goes at least 3 times as much as if you are active to inactive. So it's a very simple thing to do, is to have daily exercise. And that means that either you walk, in India, you can just walk outside, walk on the treadmill, walk in the house, in your backyard, but continue to walk is one of the simplest things. And most people would say that if you can walk 6 kilometers per hour, so that is a good walking speed. I know that is a little bit higher for the Indian population, but that is the number that you should keep in mind. 45 minutes of walking at 6 kilometers per hour is the recommendation from AHA. We say 4 miles per hour, that is 6 kilometers per hour. Cardiac rehab. So cardiac rehab is a must. So if you look at the people who have cardiac rehabilitation, this is the odds ratio, meaning that how many percent it decreases the risk of heart attack, future heart attack, or death. So if you look at the reduction is 25% reduction. These are randomized trials. If you take cardiac rehab versus no cardiac rehab, 25% reduction in future events. And more the better. So if you go to the cardiac rehab for 3 or 4 times, sessions completed, as you can see, that if you complete the sessions, 35, 36 sessions, you have the best effect. So it's not just that you have to do cardiac rehab, like anything else. If you're going to do something, you have to do it to the completion. You have to do it well. So this is an important thing, again, 30,000 patient study. And if you look at this, that the phase 2 cardiac rehab, more the sessions, you have better outcomes, not just immediately, but up to 4 years. So this is an important thing. Again, this is just saying that you got to exercise, eat right, and be motivated. Going to cardiac rehab does those things. So I want to summarize and finish to say that the comprehensive post-MI care is essential. This is the most important thing to keep in mind, that just because you had a heart attack and you got a stent and you were in the hospital, you're discharged, that's not the end of the story. That's just the beginning of the problem. So this is the beginning of your care. Now it is up to you to have the best care, and it is mostly the patient. It is not the doctor, because the financial incentive or the doctor's engagement is going to be more time consuming and less rewarding to the doctor as time goes, because it is a continuous process. So you are spending so much time to explain to the patient that you do this, that, whatever, and the amount of financial remuneration is less. So people are obviously more interested in treating the acute problems. So if you are going to have heart attack, it is up to the person to understand that you cannot let go of all these things. So close follow-up, careful attention to the lifestyle, involved physician, and a motivated patient. I think the most important one is the last one, is to have a motivated patient. So if you are in business also, if you are motivated, if you don't accept no for an answer, same thing you have to do for your healthcare, to say that everything is possible and you are going to do everything that is in your strength to get the best outcomes. And thank you for your attention. And if you have questions, feel free to.
Thank you very much, sir. Very nice scientific and evidence-based talk regarding post-TME management. Any questions regarding this topic are invited?
Of course, please.
Yes, I wonder that, Dr. Kapadia, I think in Gujarat and other places, the rehabilitation program is not more stress on that one. Not many places around also. And there was a no group rehabilitation program over here. I noticed. I don't know what's at the moment, but I think it's all consultant cardiologists that give the more stress on that one. But there is no more center, and people don't think that that is most important. I wonder what is the new program.
So this is now our, in United States. So just so, I agree with you, and I think the reasons are simple, because as I said, the most important incentive to everybody in life typically is money. So if you are going to have, healthcare also wants to reduce the cost. So that is how the money is designed, that it is the incentive in life. So if you are going to not give incentive for rehab for money somewhere, it is not going to be there. It is a good thing to do. So in United States now, if you discharge a patient without a cardiac rehab, you get less money. You say that you are not going to get reimbursement from the insurance, and if the patients are admitted to the hospital without a cardiac rehab, then you are penalized. So then now people say that they are going to use the rehab. There is enough scientific evidence that the rehab has to be done. The reason why it does not happen in a lot of centers in India is because the rehab, as I said, is time consuming, a lot of resources are used, and in that much resources, if nobody pays for it, then what is the point of doing that kind of business for the doctors? So if people understand that they will pay for the rehab, if the insurers understand that they'll pay for the rehab, or if people say that if you don't do the rehab, we will not pay you money, then obviously rehab will become more popular. But currently I know that there are several centers that are very focused on the rehab in the area, and I know that Dawal also has a very good rehab center that I visited. So there are several new centers coming up for rehab for that purpose. Dr. Manchandan, he may have an Indian perspective that is important to know, because can you give him the microphone, please?
See, as you said, cardiac rehabilitation is very effective, reduces mortality by 30%, as he also showed. But it's just not there. Even in United States and United Kingdom, more than 40% patients are just not referred. There's a lot of inertia there. So to obviate that, we had this program called Yoga Lifestyle Care, which we presented in 4,000 patients, similar to Universal Healing Program. If that we have shown, it is as effective as that, and it's very cost effective. You need a yoga teacher and nothing else. So I think if you can do this program, which is as good, we have shown already, this is presented in 4,000 patients. It's a very, very cheap method, and this was essentially for those developing countries where rehabilitation is not there, very essential. So yoga program may be exactly same, because in yoga we control the stress, we do exercise, the diet is also controlled, and tobacco cessation also comes. So all these things are part of yoga. You can do that. That program is available, very similar to Dr. Kapadia's program of universal healing, and that is the same effect as cardiac rehabilitation. I want to say that very cheap.
Thank you, thank you. And there was one other question in the back there, that where we got the microphone. So what was the question? He was waiting for a while, so I think he is next one, so you should.
Sir, I have only one thing to know about. That 6 kilometers per hour speed, as you have mentioned, for walking and all. But does it relate with the condition of heart at that time? I mean, sometimes the heart is little bit damaged because of the attack.
No, you're right. So this is why, I didn't elaborate on this, that cardiac rehab is a mechanism where you slowly, after a heart attack, this is about after the heart attack, you slowly start in a observed fashion, slowly increase your speed, slowly increase your inclination or whatever, and work on the treadmill where you're monitored. Then you are discharged from the cardiac rehab with an exact speed for you, to say that, okay, now you are going to walk at 4 miles, or you are going to 3 miles or 2.5 miles, depending on your ability, your heart function, and your situation. So a monitored program initially after the heart attack is necessary, and if you didn't have a heart attack, you can still go for a monitored program to understand that what should be your speed of walking and your way of exercising. So this is a monitored, this is where cardiac rehab is the term used for that particular exercise education.
While I feel while walking that 5 kilometers, 12 minutes a kilometer is a good speed for me.
Sure.
And I keep it little less than that.
Yeah,
so
it's up to you, right?
So I think anybody will feel it that yes, it is more for him and it should reduce. Can one feel who is affected by?
No, feeling is not the right thing. So you should have a proper, because everybody will feel different.
Thank you.
Sure.
Thank you, sir.
Okay, one more question, yeah. Just one last question. You go ahead. You can just say that, I can hear it. I agree with you. Medications are not the best way to deal with this particular problem, at least the allopathic medications. They do have serious consequences. However, acute depression that happens, let's say, after a heart attack or something that is, so we do have a cardiac psychologist in our team, so that they will give a questionnaire to the patient to say that what exactly, how you're feeling, how much fear you have, because many times doctors do not have enough time to ask all these things, so they may not even know that the guy is depressed. So if you ask some questions and it gives you a red flag that this is extreme kind of depression, then a cardiac psychologist can go to them and either do a psychological treatment or pharmacological treatment or both, and then yoga, meditation, all other things, relaxation. Some people do Reiki, some people do all kinds of things are available as alternatives to reducing the stress. But again, understanding first that this should be investigated is the key. So if you identify the problem, then you can look for solutions. Solutions to start should not be pharmacological. If you can do it without pharmacological solutions, it's obviously better and more sustained.
Thank you very much, Dr. Samir Kapadia, for such an informative and a relevant topic, and all the questions were taken up very well. Now, I invite Dr. Sudhir Shah to come up on the stage. He's a renowned neurologist, and now, a very interesting topic now we have, key to happiness, which everybody likes, you know, whether you're a patient or not a patient. So we have Dr. Sudhir Shah, and before he delivers his talk, I'll give a brief introduction. Dr. Sudhir Shah is the Director of Neurosciences and Consultant Neurologist, Sterling Hospital, Ahmedabad. He's a consultant neurologist practicing for 27 years in Ahmedabad, and he's also professor and head of department of neurology at the KM's School of Postgraduate Medicine and Research at VS Hospital, Ahmedabad. And he's also working as an honorary neurologist to His Excellency's Governor of Gujarat, and he has been conferred the Padma Shri by the Government of India in 2016. And he also got the UNO International Award for Neurology and Future Medicine in 2003, and the Jai Singh Bapa Rotating Lectureship Trophy in 2001, and was awarded the Best Paper of the Year, Gujarat Medical Journal in 2001. Very big welcome to Dr. Sudhir Shah, and I request the volunteers to welcome Dr. Sudhir Shah in the traditional video. Sir.
सर्वे सुखिनः सन्तु, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखमाप्नुयात्. At the outset, I want to thank my mentor, Professor Ramesh Kapadia, who not only taught me the science of medicine, but also the art of medicine and the art of healing. So, Professor Kapadia, I am thankful to you for teaching me art and science of medicine. I am also thankful to the organizers for giving me this wonderful opportunity on this holistic conference, which is not many times happening in the world. So I think that's a novel concept. I take note of all the dignitaries in the front row and behind. And in the next 30 minutes, I am trying to give you the composite science, the life science, why we are all here in this earth, on this earth, and that is in a very composite way. And these are the keys to happiness. Let's start with the 4 Arya Satya of Buddha. We all know that we all have problems. Everybody here, if not all, most of us, we are suffering. There is a problem. There is a problem. Suffering may be due to any cause. Somebody has health problem, economic problem, family problem, social problem, lot of. And that there has to be a cause. And if there is a cause, there has to be a way. And then Lord Buddha says, if you follow that path, you follow the way, then you will get the solution. With this basic concept, I will take up the whole talk. Let's first decide that the pain is inevitable, but the suffering is optional. My first question to the audience is, do you want to be happy? Please raise your hands. Yes. If you want to be happy, then be. What is the problem? You are in charge of your happiness and not anybody else. This is the first, most fundamental thing you should understand, that we are in charge of our happiness. Happiness is our conscious decision. It is our conscious choice. And also remember that happiness is a journey. It's not a destination. After getting this 5 crore rupees, or after getting this award, or after getting this degree, I'll be happy. That kind of mental concept is a wrong concept. Happiness is a journey. Even right now, from this moment onwards to whatever you want to achieve, or beyond that, it's all happiness. And there is no time to be, there is no better time to be happy than now. Just believe me. So fasten your seatbelts and let's start the journey of happiness. Happiness cannot be achieved by searching for it. There is no way to happiness. As Gandhi used to say, there is no way to peace. Happiness is the way. So what is the purpose of life? Friends, our whole existence is based on everybody wants happiness. Everybody wants to live and everybody wants to have peace. Nobody wants otherwise. All these concepts of LDL lowering, this, after all, is what? We want to live happily, we want to live healthily. But I have a disclaimer. When I'm saying this from this dais, it doesn't mean that I am the happiest person. Every day I am learning, I'm trying harder and harder to achieve that continuous level, constant level of happiness. It is easy to preach, but also not very difficult to practice. If I can try, you can also try. But there are certain fundamental issues. Happiness is not hypothetical, okay? But the definition of happiness varies from the person to person. And it's dynamic. Today I might feel a little happy and tomorrow I may not feel the same. So this is what we have to understand from this presentation. Happiness is the meaning and purpose of life, the whole aim and the end of human existence. There is nothing beyond that as far as common people like us are concerned. And it is the mother, happiness is the mother of health, it is the mother of creativity, it is the mother of good virtues, and it is the mother of peace. Everything is born out of happiness. So what are those 3 different levels? Why people differ in their definition? According to our Indian classical spiritual text, there are 3 levels, sattva, rajas and tamas, right? And accordingly, people define their happiness into pleasure, joy and bliss. Pleasure is what we call as indriyajanya sukh. Joy is your achievements and awards and possessions, and bliss your inner peace and inner happiness, which we call bliss. So what is pleasure? Pleasure is from, the basic animal instinct. It is sought from the outer world. There is no happiness inside in this kind of people. They seek happiness from outside. It's sensual. It's born out of those 5 senses. It is instinctual. Therefore, it is impermanent and physiological, like an action potential which we see in brain nerves. Similarly, one impulse comes, we satisfy, it goes away. That is how it is very transient. And we find pleasure in all those 5 elements of our instincts in the senses. And when we do fMRI of these people during this activity, the corresponding brain areas are enlightened in the sense there is increased blood flow or increased metabolism, and that is how we capture them. And to give you some neurology behind that, there are two important chemicals, dopamine and serotonin, which are responsible for giving those kind of transient action potential. And dopamine is the reward pathway. Like if I give you something sweet to eat today and you feel quite cozy for those 5 minutes and then you forget it. But next day at the same time, your brain gives a signal, oh, where is that sweet thing? And if you do not get it, then you will get a perpetual sense of displeasure. So there is a pain. And that pain continues till you do not get the same thing. Therefore, our spiritual text used to say, Indriyajanya sukh wo dukho ki parampara hai. So that is the pleasure. I'll be very brief because I have to go much further than all this. Joy is the next level. Those people who build empires, do conferences, get awards, have possessions of millions and billions of rupees, these people are on Rajas level. They believe in joy. There is something from within and there is something from outside, so there is a combination. It is more psychological, not purely physiological. And there are desires, but they are refined desires. Which kind of things? Service to mankind, success, creativity, achievements, awards, social interaction, recognition. Ego is the main driving force here. And simple spiritual practice like prayer, chanting, etc. So achievements, engagements, and when we do fMRI or SPECT study, we find different areas of the brain getting activated, which are the smaller brain areas, and there is typically the same set of things happen which similar kind of activities in different individually for the same thing. So there is no change, it's a reproducible event. And the chemicals here are, apart from dopamine and serotonin which are required, these are desire molecules, we have oxytocin, vasopressin and prolactin, which are the chemicals of bonding, ego and compassion. The third level, the spiritual level, is the bliss level, the highest state. Here, mind and all its activities generally tend to reduce or cease. Our consciousness becomes identified with the universal consciousness, and there is an experience of just being. So now we have moved from the level of doing and achieving, doing and having, to just a level of being. This is a kind of meditative state, and there is no external input. How do you measure this? When a person is in bliss, he is automatically in peace. In the former two levels of pleasure and joy, there will be hardly any peace. But here, peace is the parameter. So when somebody is in bliss, he will always be blissful as well as peaceful. Like mindfulness practices, kind of different yogic higher ascent practices or higher meditative states. Here, if you can see, there is a very, very limited area of the brain which gets increased blood flow and metabolism. All other brain areas become silent. There is no much activity elsewhere. And that's how it's a very profound state. And the chemicals here are endorphin, GABA, enkephalin, and endocannabinoids. And this is the summary of this graph. The next level is for us. We as physicians, most of us, as you know, are in a practice. Either you are a medical doctor or from other pathies or yogic teachers, etc. But we ourselves are unhappy and we are in agonies. We should understand that life is much larger than medicine or whatever practice you are doing. And at some stage we have to realize that we are on crossroad. One road takes us to more success, more pleasures, more money, fame and awards. The other road takes us to morality, philosophy, peace and bliss. So why we are not happy? There are lots of reasons. Classically for medical doctors, there is academic stress, professional career, corporate stress, conferences. Like yesterday evening I was talking at Chennai. Today morning I am talking here. In the afternoon I have to give a talk somewhere else. So there are lots of commitments. Look, then we have to balance the family. We have psychological issues, social problems, children issue, interpersonal problems, competition, negative emotions. Then all of us want money, fame, awards. We have to manage our time. There is a problem with traffic, now social media, staff management, misunderstanding, and hell of things. At the end, we have demonetization, and GST, and whatnot. So, enough. And out of this, we have to achieve our happiness. So now we will proceed to the main part of the presentation. This was the background. What determines our happiness? There are lots of studies, and from that I have derived that our genes confer our 20% of happiness. 10% of our happiness from all over the life is from circumstances which are transient. 20% is from health and money and etc. But the happiness really comes from our attitude, our morality, our behavior, our spirituality, our mental status, etc. Let's take about genes. Some cause happiness wherever they go, others whenever they go. So, some people are born happy, while others are born difficult. So there are 4 genes which we have identified. VMAT2, 5-TLPR, MAO, and FA. And epigenetics, the discovery of 2014 says that yes, we can change our gene expression, we can change our DNA lock, and for that we need mindful meditation, our altruistic actions, thoughts, emotions, behavior, and that we have shown in laboratories that actually we can change our DNA and GNA locks. So that is about genetics. Then circumstances. Circumstances do cast a temporary event, somebody's death or some loss of money. But if you see the overall plan of life, those circumstances do not last much long, and we tend to forget. Time is the best healer. But the more the commitment which I mentioned just now, and the more interactions with people we have, we are more unhappy. So we should reduce our commitments, and this is what I have to learn from Dr. Kapadia. We have to reduce our attachment to people. We do our work, but forget it. Then money. Money produces short-term benefits. More money will not bring more well-being. This was a wonderful study that had happened in USA, that by increasing, you have a pointer? By rising the per capita income, oh yes, that's that, thank you. Yeah, so with more rise in the income, the happiness level does not parallelly increase beyond a certain stage. So money can bring happiness to some level, but then it levels off. Money can bring security as well as comfort and pleasure. It can bring improved standard of living and education, but beyond a certain level, more money corrupts and more success corrupts. All of us, we have seen that more money and more success take away morality, relationships, health, bliss, and peace. When I was talking to some audience like this, somebody stood up and said, then Dr. Shah, this is my account number, why don't you transfer your money? It's not. What do we remember? See, somebody's awards, somebody's possessions, somebody's millions of rupees do not affect us in that context. Applause dies away. Believe me, trophies gather rust and winners are soon forgotten. But I will remember how Dr. Kapadia taught me medicine, how lovingly he taught me the holistic idea of medicine, and how lovingly he followed up my career. So this is what matters to us. For us, only 4 or 5 people and 4 or 5 friends and our parents matter. So, friends, that brings to another important concept. Happiness is a state of mind. All these things we talk about, circumstances, money, and this all, happiness actually comes from the mind. Happiness is not something that happens that money or power can command. It is only by controlling our inner experiences that we can become happy. And it cannot be reached by consciously searching for it. So, there has to be some way, and these are the keys: physical, social, moral, mental, religious, and spiritual keys. Whatever I learned in my life in all these 59 years, I am going to give now in next 10-15 minutes how really we should be happy. So first is happiness and health. Eat right, do exercise, get enough sleep, learn to relax. All these things I think has been mentioned yesterday and today, and I think The next talk is on exercise also. And you will learn more from them. Learn to relax, laugh exhaustingly, and love abundantly. So these are the ways you can do your, maintain your good health. Resistance training, venting with a friend, yoga, massage. It's not Thai massage, this is our routine massage. And laugh frequently, like this. But laugh at ourselves, not at others. Don't do that. We should, how fool of me that I did this silly mistake, like that. Smile is the main way to tell somebody is happy. When my residents ask me a very difficult question, I just smile, because he understands that does not know the answer. So smile solves many problems. Laugh frequently at yourself and not others. And when you don't know, keep silent. That's the best way. Silence avoids so many problems, I tell you. And love abundantly. You know, if you spend, this is a very powerful line. If you spend your life in judging people, then when will you love them? So love them, don't criticize. And when you love people, there is a reward. In the rostral midbrain area, in the posterior part, there is an increased cerebral blood flow and a remarkable improved parasympathetic output. Your blood pressure, your pulse, everything becomes low. Your LDL level also may be decreasing, I don't know. And so, the future of happiness, there may be some functional DBS surgery that we do for Parkinson, functional neurosurgery, etc. There are medical managements with the help of drugs for, somebody was asking, anxiety drugs, mood elevators. And there are now the people who have come up with the God helmet, happiness helmet. You know, US is a very funny country, and you get everything there. So you wear this God helmet and you feel happy. And there are some oxytocin sprays available. When you feel very disturbed, you put a spray, and you feel very fine. And I had a fantastic idea. If some of us get, angry, we should manage to push those things, and that fellow. Only thing, you have to safely reach to his nostril. That's it. So all the emotions tomorrow, my friends, would be at the tip of our hands and tip of nose. That is the way science is going. And then there are gene therapies. When I was talking of epigenetics, those 4 genes I mentioned, a day will come when in our laboratory we'll be able to take your blood, check your blood. If you are deficient in those 4 genes, we will manipulate your genes, we'll push those genes with the help of robots and nanotechnology, and you will come out, walk out of my clinic with those happy genes inside you, and you are no more the same person, you are the happier person. So that's the way things are going. Then there are certain clues. You should do music. Music therapy is a very important thing. Traveling, reading, gardening, all those, your photography, whatever pleases you, whatever hobbies you like, you should pursue them. That is very important. Then you have to be very careful in certain relationships. Emotional aspect of happiness is your relationship. Married life, children, in-laws, friends, and your professional people. These 5 determine your emotional, relational level of happiness. And happy married life is an acronym. You know that there is nothing like happy married life. But I'm so sorry. Fortunately, my wife is not here. It's a way through. I'm extremely lucky, let me tell you, that I've got a most wonderful spouse, and therefore I can do a lot of activities. What is marriage? Marriage is a way through which 2 people join together. 2 people join together to solve the problems that they never had. So this is the concept of marriage. What do women want? They want to be understood, loved, cared, validated, accepted, and they now want freedom. What do men want? Leave me alone. Happiness for children. By giving them your time, education, knowledge, culture, attitude, wisdom, and art, not the money. You give your children these things if you want them to be happy. And happiness confers in longer life. And one good friend is enough to make you happy. And I'm blessed also with very great friends. Now we go to the most fundamental. These are all, certain basic things and of course important, but the most important crux. Try to understand. We live in three worlds: physical, mental, and the spiritual world. In between you can have emotional and intellectual world also. But basically three worlds. Physical world is our macro world. Mental world is our micro world, while the spiritual world is called quantum world. The operating principles for all these three worlds are different, and we tend to mix up each other. It's not so, and therefore we don't get the desired result. I'll explain how. In the classical material, if I want to buy something, like if I want to buy a fan or a fridge or a car, I will deposit some money or gold and I will get the thing. So in exchange of something, I get something. In the mental world, and more so in the quantum world, whatever I give, I will get back. If I want happiness, I have to deposit happiness. If I want recognition, love, and respect, I have to deposit that. If I deposit hatred, I cannot get love, respect, or that kind of recognition. So whatever you give, it will come back. It's not the physical world. Second thing, the proportion in which it will come, you never know. It may be infinite. If I give a little love to this person, I might get infinite love. That is the quantum world. And the spiritual path defines different way. We, in the physical world, try to bring happiness from outside. In the spiritual world, it's not so. We are classically taught by our spiritual text that there is all happiness inside. You give happiness, it will reflect back. But more importantly, find out the cause of your unhappiness. That there is a cause. There has to be a way. So, what are the causes of your unhappiness? You find out and just eliminate or remove them. That will bring happiness. So, what are the causes of our miseries? Our desires, our thoughts, our emotions, our perversions, our attachment, our mind dwelling between past and future, our own ego, our attitude. These are the reasons why we are unhappy. Not the money, not the other things which we talk about. Remove them. And there are 5 mental approaches that you have to understand. One is attachment, thoughts, desires, ambitions, emotions, and how do we fix them? Can I have water, please? Attachment is the biggest enemy. Try to be, you do your work, but don't get attached to a person, to an object, or to a circumstance, whatever. Second, if I had more time, I would have elaborated quite a lot, but I think you are all intelligent people, you'll understand what I'm trying to say. Next level is thoughts. We are what we think, and all that we are arises from our thoughts. This human body and its projections is nothing but a body of thought. Think it over, read it over, and you will understand. With our thoughts, we make our world. My world is because of my thoughts. Your world is because of your thoughts. So be very pure in your all thoughts. Guard each and every thought that comes to your mind. If it is an impure thought, remove it. And your worst enemy cannot harm you as much as your own thoughts unguarded. Third level, desires. There is no fire like desire. The more desire you have, you will be more unhappy. If you have 2 cars and if you want 4 cars, you will be 50% happy. But if you have 2 cars and if you want only 1 car, you will be double happy, right? Ambitions. I'll quote this Gujarati word. ઈચ્છાઓ રહી જાય અને શ્વાસ ખૂટી જાય તેને મૃત્યુ કહેવાય. મિત્રો, ઈચ્છાઓ રહી જાય અને શ્વાસ ખૂટી જાય તેને મૃત્યુ કહેવાય. ઈચ્છાઓ પૂરી થઈ જાય અને છતાં શ્વાસ રહી જાય બેલેન્સમાં એને મોક્ષ કહેવાય. So we should cut down our ambition. Then next level is attitude. Is a little thing that makes a big difference. Always be positive. And win anger by forgiveness, conquer ego by politeness. This is what Lord Mahavir said. defeat deceit by transparency, and overcome your greed with donations, gracefulness, and charity. Then we come to the next level, the 5 virtues. These are simple things. All these are very simple things which we can daily practice and add up in daily schedules. Like we do exercise, like we do bathing every day, like we adore ourselves, like we eat and do. These all simple things must be practiced daily. Gratitude, appreciation, forgiveness, kindness, and acceptance. What is that? Gratitude. Feelings of gratitude release positive endorphins throughout the body, creating health. Dear friends, I must confess that ever since I learned the importance of gratitude and appreciation, I became the more happier person than I ever used to be. Thank every person that helps you. Even your driver, if he opens the door for you, thank him profoundly. The peon who brings your glass of water, thank him profoundly. From the bottom of heart, not just like by words, you know. And appreciate everybody's virtue, smallest howsoever the virtue may be. His clothes, his way of talking, his manners, his words, his speech, whatever. Appreciate from the bottom of your heart. And try to forgive people. I'll quote Ghalib here. Ghalib हमने जिंदगी को यूं ही आसान कर दिया. बहुतों को माफ कर दिया, बहुतों को माफ कर दिया और बाकी से जाके माफी मांग ली. So close all accounts, okay? And every day before we go to sleep, we should forgive people, ask for forgiveness, meet them, call them, and finish the whole account. That is called writing off your account. The first to apologize is the bravest, and the first to forgive is the strongest. Help others, compassion, and accept the things which you cannot change, right? And so mathematics of happiness is what? If you share your happiness with others, it becomes multiple. If I give my happiness to all of you, we all become much, much happier. So it multiplies. But if you have more desires than what you have, what objects you have, I think our happiness will be halved. So this is how it should. The simple formula is stop comparing, stop expecting, stop criticizing, but start sharing, start helping, start loving. Give and forgive, count blessings, and enjoy every moment and day. And that brings me to the last 5 minutes of religion, morality, and spirituality, ethics. 5 spiritual practices which all of us we should practice. There is nothing related to some god or deity. It is spirituality which is above all this. You do spiritual reading, do satsang, do chanting if you believe, do prayer, and do meditation. Whatever spiritual or philosophical reading you appreciate, you should read and try to churn every day. Meet people of same thinking, like-minded people, and do some prayer. Prayer should be from the bottom of heart, appreciating the Almighty or the Creator, accepting our own limitations, and trying to rise higher from what we are, and ultimately ask for the welfare of the humanity and all living beings on earth. Sarve sukhina santu, sarve santu nirayana. कोई प्रार्थना ऐसी नहीं होती कि मुझे इतना पैसा कमा दे मेरे बच्चे का. That is not the prayer. That is an exchange. No. Prayers are always about personal things. And when we do prayer, we have done some SPEC study and we have found that there is an increased cerebral blood flow in the limbic system, and that confers to autonomic nervous system, which improves our parasympathetic outflow, our pulse, blood pressure, respiration, calmness, peace, etc. improves. And that is the direct evidence for that. And lastly, meditation. I cannot overemphasize the importance of meditation. It is the master key. It's an antidote to stress, it is an antidote to coronary, it is an antidote to carotid, and it is an antidote to cancer, a lot of things. And oftentimes we have seen, and meditation doesn't mean that you just close your eyes and do something. Meditation is controlling your processes, internal processes, and look inside. It can be like the Chinese method called Qigong. I'm sure you are all well versed with the Indian system, so I brought the other things. And there are several techniques. You focus on breathing, focus on an object or light, focus on a sound, focus on a thought, focus on a sensual object, or sensory perception like in Vipassana, do imagery, or you do soul meditation. Even this is meditation. Sufi meditation, if you have seen in Turkey, I think the video is not linked. Audio sound is not there? No problem. That's fine. So this is also a type of meditation. And there are several other ways which I don't have time, but I will definitely put the remark that what happens during meditation. Now this is the brain, this is the frontal area, and before meditative act, in the prefrontal cortex, this red part shows blood flow. But after the meditation, single session of 60 minutes, there is improved cerebral blood flow in the prefrontal area. And what does this area do? This area of the brain controls our intelligence, executive power, planning, higher intelligence, memory, behavior. All these things comes from this. So even a single session of meditation has been unequivocally proved on our studies that it improves our behavior, intelligence, etc. At the same time, more importantly, what does it do? This is the parietal area, which is here in the left side, left parietal area, and here the blood flow decreases. What does it do? That means this area is the area of orientation to time, place, person, manifestation of ego, manifestation of desires, ambitions, what we all discussed, the cause of our miseries. All this is controlled from this area basically. And dear friends, during meditative act, the whole processes of mind which keep us unhappy, thoughts, emotion, desires, ego, attitude, attachment, all this goes down. So improvement in your pragya, intelligence, memory and behavior, and reduction in your flimsy mental processes is the outcome of meditation. And therefore, friends, let us all do meditation. So friends, what is the address of meditation? Pin code is 00000. It's not outside. Happiness is inside. One spiritual mention, meditation hall, philosophy lane, peace society, charity chalk, morality area, religion station, or whatever you want to put here. But it is 000. So my friends, I have another question now. Do you want to be happy? Then be, that is what I started. But the real answer is, if you want to be happy, then just be yourself. Cut down connections from outside. Go inside. And this happiness is the mother of health, of peace, creativity, productivity, performance, etc. And in this holistic conference where we are talking about our health and all other aspects of medicine, I think this would be an addition to the dimension of what we talk on the levels of chemicals and exercise and these. I think we have to pursue this. And that is the root cause why we are here as a human being on this earth. We have to be happy. And that happiness, these are the different ways that I have understood, I brought for you. You can improve on that and you can add to that. I think from this dais, I want you happiness and peace for the rest of life. Thank you so very much.
All done, sir? All done? Yeah. Sir. No problem, sir. Thank you very much, Dr. Sudhir Shah. And so the wonderful topic, that brings back to our theme is Holistic Cardiology Conference. And we have a great portion of the holistic part today right now. And a big round of applause for Dr. Sudhir Shah. And I request the Vidyapit volunteers to present a memento, a Gandhian clock. You can just face the... Thank you once again. And we move over to the next one. Thank you very much, May I invite Dr. Anish Chandarana to come up on the stage, please. He's the next speaker. And again, a wonderful topic, continuing the holistic part of it. Exercise, how, what, and when. Please. Before he starts, I give a very brief introduction about Dr. Anish Chandarana. We'll just load your, please have seats. Yeah. He's a DM in cardiology and the fellow of the American College of Cardiologists with the SIMS Hospital, Ahmedabad. He was the founding partner and director of the Green Eco-Friendly SIMS Hospital, and he has been a clinical cardiologist and cardiovascular interventionalist since 1999. He had a brilliant academic career with gold medals at almost each level. He's an extensive teaching experience. He was an assistant professor at the UN Mehta Heart Hospital and Institute of Cardiology and Research Center in Ahmedabad, and has been part of various international and national research studies, and that's one of his major areas of interest, research, and he has traveled extensively across India to create awareness in people about prevention of cardiac disease through lifestyle improvement, and organized many diagnostic and therapeutic camps across Western India. He is the member of the Indian Medical Association, India, and Scientific Committee of IMA. Welcome, sir, and I'll request the volunteers to welcome him in the traditional Vidyapit style. Just face this side, sir. Yeah. Sutarni auntie, ane khadi normal.
Respected seniors, dear friends, at the outset I would, from bottom of my heart, thank Sri Kapadia Sahib, my friend Dr. Dhiren Shah, and all those who are involved in organizing this conference, and also would like to congratulate and compliment them for creating such a high level of awareness that it's not only medicine, it's not only angioplasty, it's not only bypass, but there are so many things which may be as powerful and as solid in prevention and treatment of heart disease. I don't have any conflict of interest except for the fact that, as was well said in last lecture, that I want to gather the happiness of sharing all those most important informations which I gathered through my reading, through my experience, and through my own personal life. Somebody asked me, Anis, what is most important in your life after I delivered a lecture on fitness? And I said that fitness and happiness. Because fitness adds years to the life and happiness adds life to the years. So this is very important. When previous president of US, Barack Obama, wrote a letter to Dr. Dean Ornish that what I should be taking care of while adopting strategies to improve cardiovascular health of Americans, at that time he wrote wonderfully well, and which is so important for all of us. He said that what we eat, how much we exercise, whether or not we smoke, how we respond to stress, and the quality of our relationship and social support may be as powerful as drugs and surgery in treating and preventing heart disease. And he went further to say that we don't have to wait for a new breakthrough in medicine or surgery. We just need to put into practice what we already know. So this is from somebody who is so learned and so knowledgeable. So diet, exercise, meditation, yoga, happiness, all these points are very, very important. And perhaps we as doctors are too much reliant on medicines and drugs. We are not ready to look into various other aspects which can help not only us but our patients also. If you look to the WHO data about preventable cause of death, you look here and they have said beautifully well that lack of physical activity is responsible for at least 2 million deaths a year. Lack of physical activity is directly responsible for death. And then there are so many other features. There are so many other features which say that if you are not physically active, if you are not taking exercise, there is very high chance of death. So just people are not exercising, people are not physically active leads to so many problems. There was a beautiful trial called as InterHeart. done by Dr. Salim Yusuf. And what he said, 9 modifiable risk factors account for 90% of the heart attack. So 90% heart attack, they are because of all this: smoking, lack of fruits and vegetable intakes, excess of alcohol, lack of exercise and physical inactivity, lack of social support and emotional relationship, stress, diabetes, hypertension, and lipids. So they said that 12% of first heart attack can be directly attributable to lack of exercise. માણસો ખાલી કસરત નથી કરતા એટલે 12% heart attack એનથી આવે છે. This is such an important science. So what is fitness? Fitness can be defined in various ways, but one important point is when your body systems are working well, મારા હાથ, પગ, કાન, આંખ, નાક, stomach, intestine બધું બરાબર ચાલે, તો then I'm fit. So this is very basic and simple point, but somebody said a wonderful definition of physical fitness, and to me, it also encompasses the mental fitness. What is that? I can be said to be physically fit only if I can carry out my daily task with a lot of vigor, alertness, without undue fatigue. If I'm a doctor working for 10 hours a day, I should be able to do that very happily with vigor, vitality, and energy. Second, and with ample energy to enjoy leisure time pursuits. જે હમણાં આગળ વાત કરી કે આપણે થોડો ફ્રી ટાઈમ હોય, દિવસમાં 2-4 કલાક હોય, એમાં હું સ્પોર્ટ્સ કરતો હોઉં, મેડિટેશન કરતો હોઉં, બીજા કંઈ કરતો હોઉં, ગાર્ડનિંગ કરતો હોઉં, તો એ પણ હું ખૂબ જ રસથી અને પ્રેમથી અને શાંતિથી કરી શકવું જોઈએ. એન્ડ યેટ I have mental and physical fitness to meet with unforeseen emergencies. રાત્રે 2 વાગે પેશન્ટ આવે તો પણ હું દોડીને એને ટ્રીટ કરી શકતો હોઉં જોઈએ. This is to me a wonderful definition of fitness. There are so many other aspects which can be included in fitness. જેમ કે મને બરાબર ઊંઘ આવે છે કે નહીં, હું એક્સરસાઇઝ કરવા માટે પ્રેમ કે રસ ધરાવું છું કે નહીં, whether I feel fresh when I get up, whether I feel fresh throughout the day, whether my bowel habits are good or not, for female whether menses are regular or not. There are so many things, but fitness to me depends on how do we deal with our body and mind on daily life. That's very, very important. How do I deal with body and mind? So what is exercise and what is physical activity? Physical activity is any bodily movement which leads to energy expenditure. Say, for example, I am delivering a talk. At that time, I am moving my hands. So this is physical activity. Somebody is sitting, got up, went to the toilet, came back. It is physical activity. So physical activity is very, very important. The another point is exercise. Exercise is a more structured, repetitive physical activity. Say, for example, I design कि मारे आ सीढ़ी છે 10 વાર ચડીને ઉતરી જવી છે. So this is exercise. So exercise is more structured physical activity. But both of them are important. I have to have a spare time for exercise, and I have to be more physically active in my day-to-day life. Why physical activity in day-to-day life is important? This data came in 1953, British Journal of Internal Medicine, 1953 they studied the conductors and drivers of the city for 40 years. And 40 વર્ષે એમને શું સંશોધન મળ્યું કે drivers has a risk of heart attack which is 3 times more than conductors. A very important point, because conductors keep on moving, keep on walking, while drivers keep on sitting. So those who are conductors, movers, they have less risk of heart attack, and that is the importance of physical activity at working place. We know that when you do regular physical activity and exercise, there are a lot of benefits. It reduces my blood pressure, it optimizes my body weight, it improves my muscle and bone functions, it reduces platelet stickiness, it improves endothelial function. There is huge data available in the medical science. A very important point, તમારામાંથી ઘણા aware હશે. In today's world, CRP, HSCRP is considered a very important inflammatory marker which suggests the risk of future cardiovascular event. ભવિષ્યમાં મને એટેક આવશે, સ્ટ્રોક આવશે, મારું હાર્ટ કે સ્ટ્રોકના કારણે મૃત્યુ થશે, એ ડિફાઇન કરવા માટે એક HSCRP નામનો ટેસ્ટ આવે છે. If that test is high, my chance of heart attack and stroke is high. So they segregated the people based on their fitness. Those who were highly fit, those who were moderately fit, and those who were unfit. And they underwent HSCRP testing. What was found is those who were highly fit, their HSCRP level was less, while those who were unfit, their HSCRP level was high. So that suggests those who are unfit have a high risk of heart attack and stroke. So simple fitness defines a lot. Another important point, we believe that cholesterol is important, and it is important, no doubt. There is no question on this earth that cholesterol, serum cholesterol is important, but then it's not everything. There is another data in trial which said that there were people, they picked up the people whose cholesterol was well controlled. Their total cholesterol was less than 150 milligram, and their LDL cholesterol was less than 75 milligram. So is that fine? I mean, less than 75 LDL cholesterol for normal people is good. So they picked up these people whose cholesterols were controlled, and they divided them into 2 parts. those who were unfit and those who were fit. So those who had normal cholesterols, but if they were unfit, the risk of heart attack and death was 5 times higher than those who were fit. So having cholesterol normal doesn't mean everything. Fitness counts more important than cholesterol. That was said in this study. This study said that out of all risk factors, fitness was the most important, and this study was published in a circulation, which is a respected journal across the world. We all know that exercise improves HDL cholesterol, but it improves HDL cholesterol only in the people who are obese and only in the people whose triglyceride is high. HDL is something which is a gift of ancestors. It can't be modified much by exercise, but even little increase in HDL is good. If your exercise improves your HDL by 5 to 10%, but you know that 1% increase in HDL reduces risk of heart attack by 3%. So if my exercise improves my HDL by 5%, my risk of heart attack is reduced by 15%. And a very important point, when you do exercise on a regular basis, it does not alter LDL cholesterol and HDL cholesterol much, but it changes the size of particle of LDL and HDL. For those who are physicians here, those who are in other stream, science has found out that it's not only the level of LDL and level of HDL, but the variety of LDL and HDL that is also important for heart attack. So when you do regular exercise, it changes the variety of LDL and HDL from more harmful, from more heart attack giving to less harmful or more effective to give good health, and that was proven well. When you do regular exercise for years, in association with other risk factors modifications like stopping tobacco consumption, stopping excess of alcohol, taking care of diet and nutrition, you get small changes in all risk factors. Say for example, I give you an example of my friend. He was 35 years. He was 35 years and his weight was 82 kg. He was a doctor. Blood pressure was 146 by 94, mildly high. LDL cholesterol was high, HDL cholesterol was low. Glycated hemoglobin was marginally high. His HSCRP was high. He came to me. I explained about diet, nutrition, and exercise. And after 3 to 6 months, he came back to me. All the parameters were changed marginally. His blood pressure from 146/94 went down to 134/90. There was no big change in blood pressure. There was no big change in cholesterol. There was no big change in HDL. There was no big change in sugar. Everything got improved by 5 to 7%. But if you put these figures into risk calculator, there are risk calculators available that what is your risk of heart attack and stroke in next 10 years. If you put the previous information into risk calculator, his risk of heart attack and death was 25%. But if you put these new features into this risk calculator, his risk of heart attack and death is only 5%. So risk of attack and stroke and death, which was 25%, came down to 5% only by diet control, exercise, and smoking cessation. So individual parameter may vary less. When you exercise, your weight may go down by 3 to 4 kg. You say, oh, I'm not getting any help. Don't worry. Your BP may reduce by 2 to 4 millimeter of mercury or 6 millimeter. Don't worry. But all these risk factors, when put together, it's not 1 plus 1 is 2, but it's 1 plus 1 is 11. So that is the magic of exercise. It also does a lot of other things. It improves your muscle performance. It improves your lungs and heart stamina and endurance. It gives you a lot of good mobility and flexibility. It improves your neuromuscular coordination. If you want to live long and live happily with adequate physical fitness, exercise is very important. It improves your balance and posture. And there are a lot of benefits of weight loss and physical activity described across the body, starting from head to toe. It improves your risk of arthritis. It improves your bone and muscle health. It reduces risk of gallstone. It reduces risk of cancer. It reduces risk of heart attack and stroke. So a lot of things. But the most important point is I need to do exercise. And that's very, very important. Now there are two kinds of exercise. Two kinds of exercise. One is which we used to say as cardio or aerobic. Tamarathi ghana loko se term janta hase aerobic exercise or cardio exercise. Now a new and more comprehensive term has been coined that is called as endurance exercise. Ke jenathi tamaro stamina vade. What are those exercise? Walking, jogging, running, swimming, cycling. All this is endurance exercise in which tamara pulse vade, tamaru blood pressure thodu vade, tamaru respiration vade. So this exercise stretches your cardiorespiratory system. And this exercise is very, very important to be done on a daily basis. What is most important is when you walk or jog, you should have a good pair of shoes to prevent injury to bone and muscle. And there are charts available which kind of exercise leads to which kind of calorie burning. So you can adjust to those charts. Another important point is one can decide what is my level of fitness as far as heart, lungs are concerned, as far as bone and muscles are concerned, and one can choose the exercise. There is another form of exercise which we used to say anaerobic exercise. Now there is nothing like anaerobic exercise. Every exercise has to be aerobic. There has to be adequate amount of oxygenation going inside. So that is called as resistance training or strength training exercise. And WHO, American College of Cardiology, all have made it compulsory that you should be doing at least 2 to 3 times a week, 30 to 40 minutes. Muscle building is just for the look. Muscle building is extremely important from so many perspectives. Your muscles are the largest waste basket of your body. Whatever toxins which you eat on diet, whatever toxins which are produced in body, if you've got more muscle mass, they'll be better absorbed and they will affect you negatively very less. In India, there is high risk of cardiovascular and metabolic disease. What are the reasons? One is, yes, we know that genes are important, but we cannot keep crying on genes. My genes are genes and I cannot change them. But then it is environment, lifestyle which has harassed us. If you look to the Indians who have cardiovascular and metabolic disease, many of them are not really those heavily obese. But a term which has been coined for Indian is thin, lean, fatty Indian. What does it mean? An Indian may be of 50 kg weight, 5 feet 6 inch height, looks very thin, but if you look to the body proportion, his muscle and bone are less, and body proportion and percentage of fat is high. And that body percentage of fat, that visceral fat, is a killer. And that can be reduced in proportion by both the exercise, but weight training or resistance training is extremely important. When you start resistance training, it's important to undergo a health checkup and start doing it under supervision, because it is something where if you don't know well and don't do well, you can injure yourself. Those who do not want to feature into aerobic, anaerobic, endurance, strength training exercise, they can go to ancient Indian system of yoga, pranayam, asanas. And then there are so many yoga asanas which can include everything. Say, for example, Surya Namaskar. It combines everything. It includes cardio exercise, it includes resistance training, it includes breathing exercise, it includes stretching, and it includes also abs exercise. So Surya Namaskar is such a comprehensive exercise that if you start doing on a regular basis, you need not do anything else and you can keep doing that. So what is the regime of exercise for an Indian? We need to exercise 50 to 70 minutes a day. Make sure that it is regular 5 to 6 times a week. Divide your time into 5 different types of exercise. One is cardio, that is walking, jogging, running, cycling, swimming, gardening. Resistance training, weight training at least 2 to 3 days a week. You have to do something for your abdomen because tummy comes up for almost everybody in India after the age of 30. So should be doing floor exercise, should be doing twisting, etc. You should be doing stretching on a regular basis. Otherwise your bone gets hard, your bones get brittle, and then you lose the flexibility. And you should be doing breathing exercise on a regular basis. You should be doing at moderate intensity. That depends on individual, that what is your level of fitness. Another important point, people say that I don't have a time at a stretch for 60 minutes. Can I do in bouts? I have 15 minutes now, I do exercise. Then in the evening, I would have 15 minutes. The science has enough data that whatever exercise you do in 10 minutes, it all together works as 1 hour complete. So don't hesitate anytime. Even if you have 10 minutes, keep walking. If you have 5 minutes, do something. Any time invested in exercise counts for your fitness and health, everything. You can exercise 10 minutes 5 times a day, it works like 50 minutes of exercise. So that's very important. When you start a regular exercise, warm up and cool down is important. Adequate hydration is important. When you start exercise, your stomach should not be totally empty, nor it should be too full. There are certain warning signs which you need to understand. When you exercise, you need to understand there are certain signs where you have to stop. Suppose તમને બહુ શ્વાસ ચડે, suppose માથું દુખવા માંડે, suppose આંખે અંધારા કે ચક્કર આવે, disproportionate perspiration થાય, disproportionate શ્વાસ ચડે, તો then you have to stop. This is warning sign. And don't do exercise when you are ill, because in illness, exercising can harass you. A wonderful data came that sitting is another smoking. The data said that sitting increases your risk of death, heart attack and stroke in dose-dependent manner. If you sit for 2 hours a day, your risk of heart attack is there. If you sit for 4 hours, risk doubles. If you sit for 6 hours, your risk doubles. So sitting increases risk of heart attack in a dose-dependent manner. So easiest form of exercise is stand-up. Standing is the easiest exercise. So those who stand for at least 2 hours, they are doing something to reduce their risk of heart attack. So this is all data and science. Another important, people do ask a question. that should I do vigorous exercise to help myself? No, the answer is no. If you do vigorous exercise, you are young, fine. But if you are totally inactive, from that, if you become moderately active, most of the benefits are achieved. If you are totally inactive, કે હું કોઈ જ કસરત નથી કરતો, આખો દિવસ બેસી રહું છું, કદાચ દિવસમાં અડધો કિલોમીટર ચાલતો હોઈશ, બાકી કંઈ નથી કરતો, you start walking 4 kilometers a day, 3.5 kilometers a day, and then most of the benefit is achieved. For those who are enthew, if they keep on increasing exercise, they will get additional benefit, no doubt, but the additional benefit is small. So that is quite reassuring that from totally being inactive, if you become mild to moderately active, you get almost all benefits. So those who are senior citizens, those who do not have time, there is a big reassurance for themselves, okay, fine. I have been talking about exercise for primary prevention and exercise in healthy people, but even exercise in people who already heart disease has shown that those who do moderate, mild to moderate exercise, they get tremendous benefit. There are important questions of exercise which I have answered. There has been good data. I have not gone into too many of trials, but trials do say that. If you want to prevent, say for example, this trial said if you want to prevent diabetes, they accepted 3 ways. One is people were said to go for lifestyle modification. Then people were given a medicine which can prevent diabetes. And then people were given a placebo. And what was found is lifestyle modification was the most effective tool to reduce the risk of diabetes, more effective than medicine. So we have plenty of data that lifestyle helps a lot. But the most important point is every morning my brain tells me to exercise and my body laughs at छोड़ो यार आज सर्दी छे आज टाढ़ छे आज ताव छे आज रविवार छे आज शनिवार छे आज काम बहु छे. No, it should be a habit on a regular basis. Exercise can make a lot of wonders for you. It doesn't only improve your heart, lung, bones and muscle, but it gives you tremendous energy and strength. A person who does regular exercise versus a person who doesn't do regular exercise, his body language will be different, his posture will be different, his happiness will be different. Exercise is a big stress buster. You do exercise and tell me after 1 year that you will feel that I am able to tackle my stress better. Exercise makes you sleep better. Exercise also makes you look good. There are so many youngsters here. You will look better. And it improves your self-confidence. Your presence in the society, your presence in this world, you will be doing with more confidence. Alone exercise is not enough. You have to have a good nutrition. And there has been a lot of data, but I'll just produce one slide. Mediterranean diet, which is quite traditional Gujarati diet, quite traditional, which has high amount of anaj, kathol, legumes, cereals, good amount of fruits and nuts, badam, pista, akroot, good amount of vegetables. Those who are fish eaters, good amount of fish, taking good fat. See, people got somewhere miss up. Good fat is good for life. And what is good fat? Badam, pista, akroot is a good fat. Fish is a good fat. So you need to take those who take alcohol, moderation of alcohol, low meat and meat products, low dairy products. When you do this in association with all those ancient Indian things like ginger, turmeric, fenugreek, clove, cardamom, and if you create a diet, that can help you a lot. Smoking is more dangerous than Osama bin Laden. More dangerous. People put their entire attention to kill terrorists. Yes, terrorists should be killed. But to me, the biggest terrorist of mankind is smoking. So it's very, very important. Not only we do that for ourselves, our families, but we have to keep working to change the habits and behavior of society, because that is something, if we can do that, we will help the society to a great extent. A lot of things have been said about alcohol, but one thing which I'll say that in Indian population, there is no medical ground to promote alcohol as a healthy way of life. There is no data. Even in the world, there is no randomized controlled trials to say that alcohol helps the life. They were only observational data obtained from retrospect analysis of various registries that people who took alcohol in moderation, they had some better aspects. But there is no randomized controlled trial. So people cannot say that. Those who do take alcohol because of some reasons, moderation is very important. But moderation is such a slippery slope that very few people can navigate it well. So that's why alcohol should be avoided by all means. Sleep is very important. Fitness is not achieved unless sleep is good. Quality of sleep and quantity of sleep. There is good data which says if you sleep less than 5 hours or if you sleep more than 8 hours, the risk to heart attack and stroke is high. So 5 to 8 hours is something which is quite personal. I mean, I cannot say that the thumb of rule is 6 hours, 8 hours. Depends on your activity, age, your mindset, etc., etc. But it's very important. And prayer before sleeping is something which can ease your mind. Not seeing television after 8 p.m., not attending mobile phones, not going to social media after 8 p.m., they all help you to get a better sleep. In today's world, social media is something which is a serious harassment. And that's why after 8, you have to start something which cools your brain. There are so many killers of mind which have been well discussed in previous lecture, but unless I discuss this, fitness is not complete. That's why, and there are so many supporters of mind. Meditation is wonderful, but then there are so many things which support mind. Humor, music, reading, creativity, gardening, so that you can create a wonderful mind. So coming to conclusion, dear friends, let us make a choice. It was well said in previous lecture that to be happy is a choice, to do regular exercise is a choice, and there is terrific capacity with the human minds. There is terrific capacity. It's only we do not trust that. Let me tell you, those who made a choice to come here in this conference are sitting in this room. Those who made a choice that Sunday morning mare શાંતિથી 10 વાગે ઉઠવું છે ને ક્યાંય કોન્ફરન્સમાં નથી જવું, they are at home. Those who made a choice to go for shopping to some mall, they have gone to shopping. So what you made a choice, you are doing. You all are sitting here because you made a choice. So there is tremendous power in your mind, tremendous power in your choice. So make a choice that I want to exercise 60 minutes a day. That's it, no go. Make a timetable. It is quite unfortunate. Most of the doctors do not have a good timetable, particularly when they are very active in their life. Do exercise when your stomach is neither full nor empty. Don't do exercise when you're ill. Good shoes is important. That's where you have to invest. Otherwise, you can injure your muscles and bones. And comfortable clothes. You can make friend circle and you can do exercise, you can promote. You can listen to music or something at that time. Take adequate water or some juice while doing exercise so that you are not dehydrated, your electrolytes are maintained. Warm up and cool down is very important. One important point to assess the intensity of exercise is talk test. What is talk test? When you walk, when you do any kind of exercise, talk to your friend. If you can talk the way I am talking, if you can talk very happily without any inhibition, then you are underperforming. If you talk and you are not able to, then perhaps you are overperforming. So do a talk test and you can judge the intensity. Divide your exercise into all elements. Single exercise doesn't give you the perfect fitness. There are people who do only cardio. It's good. Rather than doing nothing, it's good to do cardio, but you have to have resistance training 2 to 3 times a week. You have to have stretching. You have to have some exercise to keep your stomach flat, and you should be doing pranayama. Love exercise and feel happy. Thank you very much for your kind attention.
Thank you so much, sir.
Yes.
You have cleared our doubts very nicely. So I am requesting you all, if you have any questions, you can ask.
Anybody comments, suggestions, points? Anybody has willing to get some guidance for personal exercise?
ગુજરાતીમાં ખૂબ સરસ ચંદ્રારાણા સાહેબે સમજાવ્યું અને હેલ્થનું એવું છે કે ઇટ ઇઝ બેટર દેન ક્યોર કે રોગ આવતો અટકાવવો એ વધુ સારું છે રોગ આવો તો સાહેબને હું તો નાનો માણસ છું થોડું રિક્વેસ્ટ કરીશ કે જે આપણી ડાયટ સિસ્ટમ છે એ સ્પેશિયલી અત્યારે કે આયુર્વેદમાં નિયમ છે કે જમતા પહેલાં 2 કલાક 1 કલાક અને જમ્યા પછી 1 કલાક કોઈ કશું લેવું નહીં. પછી જે લોકો શ્રમ નથી કરતા તેણે સવારનો નાસ્તો એવો મારા જાણવા મુજબ થોડો આયુર્વેદમાં અભ્યાસ કરું સ્ટડી કરું છું. મારી પાસે એક પુસ્તક પણ છે બહુ સરસ હું સાહેબને બતાવી છે કારણ કે આ ગુજરાતીમાં હું થોડું કન્ફ્યુઝ બોલી શકું. બીજી વાત એ છે કે સાંજે મોટા ભાગે આપણા લોકો છાશ લે છે. હું આઈ એમ કમિંગ ફ્રોમ પોરબંદર. તો છાશને આયુર્વેદમાં છાશ અને દહીંને ઝેર કીધું છે. બીજું આપણે મોટા ભાગે અહીંયા જે લોકો છે તે હું તો નાનો માણસ છું એ ફ્રીજનો બહુ ઉપયોગ કરે સાહેબ રેફ્રિજરેટર. મારે ઘરે 2 પડ્યા છે આઈ ડોન્ટ યુઝ. મારા છોકરાએ આપ્યા મેં છોડી દીધું. એનો કબાડ તરીકે ઉપયોગ કરીએ. આપણું જે ટેમ્પરેચર છે બોડી ટેમ્પરેચર પછી જે આપણું દિવસનું ટેમ્પરેચર છે અને જે તમે ફ્રીજમાં જે પાણી રાખો છો સાહેબ એ આખું વિરોધાભાસ થઈ જાય છે ને. જે ટેમ્પરેચર છે મારા બોડી ટેમ્પરેચરથી એનું ઠંડુ પાણી પીવું તો મારો જે અગ્નિમાંદ આયુર્વેદમાં મોટા ભાગના રોગો અગ્નિમાંદથી થાય છે. સાહેબે બહુ સરસ વાત કરી કે મારો જ્યારે ચૂલો છે અગ્નિ છે એ જ્યારે લો થઈ જાય છે હાઇડ્રોક્લોરિક એસિડ ડાયલ્યુટ થઈ જાય. તમે જ્યારે પાણી પીઓ બહારથી આવે ફટાફટ ઠંડુ પાણી જમીને ફટાફટ ઠંડુ પાણી પીઓ ધીમે 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 અગ્નિમાન થવાથી રોગો પેદા થાય છે. એમ આયુર્વેદ કે સાહેબ, મેં સ્ટડી કર્યું છે, સાહેબે બહુ સરસ સમજાવ્યું. તો મારો કયો શું મુદ્દો છે કે જે લોકોનું ડાયટ સિસ્ટમ જ્યાં સુધી આપણે નહીં સુધરે. પછી બહુ સરસ વાત કરી સાહેબ આપ કે મોટા ભાગે જે શ્રમજીવી, આઈ એમ કમિંગ ફ્રોમ ફાર્મર ફેમિલી, ખૂબ કામ કર્યું છે. આઈ એમ 71, BSc છું. અહીં મારી બાજુમાં જ કોલેજ હતી, CU શાહ, અને હું ગુજરાત વિદ્યાપીઠમાં ડેઇલી ગ્રંથાલયમાં સાહેબ પુસ્તકો વાંચવા આવતો. ગાંધી બાપુએ એવરી એસ્પેક્ટ ઓફ લાઈફ, આ ભૂમિ ઉપર ઊભા છે ત્યારે આપણે યાદ કરીએ કે ગાંધી બાપુએ બધા ઉપર પ્રયોગ કર્યા. ઇવન એની ડાયટ ઉપર, આરોગ્ય ઉપર, આપણા ખાનપાન ઉપર. અને બાપુએ બહુ સરસ એક કર્યું કે ગુજરાતીઓ દાળ ખાય છે, અને ડાયટ સિસ્ટમમાં જે દાળ છે આપણી સૌથી પચવામાં ભારે. ખાવે જો મગ તો આવે પગ. આયુર્વેદમાં સૌથી સારું જે છે એ મગને કીધા છે.
So I think for the sake of time, we'll have to make it concise. But most
Please,
important
yeah.
point is, like, see, many streams have different thoughts. They are based on their own data and researches. But still, I believe કે જે આપણે એક શાસ્ત્રમાં સરસ કહ્યું છે ને, અતિ સર્વત્ર વર્જયેત, એ સમ્યક મધ્યમ માર્ગ કાઢવો એ બહુ જ જરૂરી હોય છે. યસ યસ.
પ્લીઝ સર, આપણે બીજાને ચાન્સ આપીએ. પ્લીઝ સર, આપણે આપ સેશન પછી આપ મળી શકો છો. થેન્ક યુ સર. One more question, please. We can take more questions. Please, please.
કઈ ઉંમરે કેટલી એક્સરસાઇઝ થવી જોઈએ? ઇફ યુ આર અબાઉટ 70, ઇફ યુ આર અબાઉટ 80, સો ઇઝ ધેર એની લિમિટ ફોર ધ એજ?
ગુડ પોઈન્ટ. સી, એક્સરસાઇઝ તમારે કેટલી કરવી, ઇટ ડિપેન્ડ્સ ઓન સો મેની થિંગ્સ. વન ઇઝ યોર ફિટનેસ લેવલ. તમારું હૃદયનું ફિટનેસ કેવું છે, ફેફસાનું ફિટનેસ કેવું છે, બોન ને મસલનું ફિટનેસ કેવું છે. વન. સેકન્ડ, કે તમારે એક થરો હેલ્થ ચેકઅપ કરાવી લેવું પડે ઇન ટર્મ્સ ઓફ BP, પલ્સ, ડાયાબિટીસ, શુગર વગેરે. અને જો કોઈ દિવસ કસરત નથી કરી તો 70 વર્ષે પણ ચાલુ કરી શકાય, પણ ધેન અંડર ધ સુપરવિઝન એન્ડ ટ્રેનિંગ. જે આગળ આપણે ડૉક્ટર સમીર કાપડિયાએ વાત કરી, કોઈ પૂછતું હતું કે રિહેબિલિટેશન પ્રોગ્રામ જે ચાલે છે, ડૉક્ટર દોશી કરે છે, અમદાવાદમાં બી થોડાક શરૂ થયા છે. તો 70 વર્ષે જો મારે એક્સરસાઇઝ કરવી હોય, હેલ્થ ચેકઅપ કરાવો, અંડર સુપરવિઝન ચાલુ કરો, 3 મહિના સુધી શીખો અને ધીમે ધીમે તમારો સ્ટેમિના આપ લઈ જાઓ. સપોઝ કોઈ વ્યક્તિ 10 થી 15 મિનિટ કરે છે શરૂઆતમાં, 20 કરશે, 25 કરશે, 30 કરશે, પણ 30 to 60 minutes is something which one has to do on a daily basis.
Excuse me, sir. Hello.
Yes.
After major surgery of CABG or total knee.
The madam is. Bolo.
Wait, please wait.
Yes. Perfect. Undoubtedly, yes. Undoubtedly, yes. Yes, sir.
After major surgery of CABG or total knee replacement.
Yes.
When the exercise can be started and how much it can be done?
Oh, very good. Like, see, I'm from cardiology, so I can tell that very well. In fact, અમારું પેશન્ટ બાયપાસ થાય ને ઘરે જાય એ પહેલાં જ હોસ્પિટલમાં કસરત કરતું થઈ ગયું હોય. લાઈક ડૉક્ટર ધીરેન શાહી છે તો બાયપાસ થાય, 3 દિવસ પેશન્ટ ICUમાં હોય, 4થા દિવસે રૂમમાં જાય, 5મા દિવસે તો લોબીમાં વોકિંગ ચાલુ થઈ જાય. તો દેટ ઇઝ ઓલ્સો એક્સરસાઇઝ. સો બાય 10 days or 9 days when patient goes home, દિવસની 5, 10, 15 મિનિટ તો ચાલતું હોય. પણ પેશન્ટના ઘણા બધા ફેક્ટર્સ ધ્યાનમાં રાખવાના છે. એમાંનું એક છે હાર્ટનું પમ્પિંગ કેવું છે, વોટ ઇઝ ધ પમ્પિંગ ઓફ હાર્ટ. બીજું, દર્દીને ઓવરઓલ જે સ્ટીચ લીધા છે એની રિકવરી કેવી રહી છે, દર્દીની મેન્ટલ રિકવરી કેવી થઈ રહી છે. સો વેન ઇવન બાય 5 to 7 days યુ સ્ટાર્ટ વોકિંગ, તમે ધીમે ધીમે બ્રિથિંગ એક્સરસાઇઝ ચાલુ કરવામાં આવે છે. આ લોકો કેટલાક ડિવાઇસ બી આપે છે જેને સ્પાયરોમીટર કહેવાય, કે જેમાં તમે જોશથી ફૂંક મારો એટલે તમારું બ્રિથિંગ સારું થાય. પણ જનરલી મોસ્ટ ઓફ ધ પીપલ કમ ટુ a good baseline exercise level by 3 months of bypass. પણ એમાં જે અગેન આગળ વાત કરી તેમ કે એડપ્ટિંગ a rehabilitation program is very, very, very important. Getting bypass or angioplasty done is very important. Equally important is to take a rehabilitation program and make your mind and body again perfect and normal. So by 3 months you can be on a routine track. But again, તમારે ડૉક્ટરની સલાહ બી જરૂર છે. If your pumping of heart is less, in that case certain intensity of exercise you cannot do.
Sir, sir, you told that exercise on full empty stomach, complete empty stomach is not recommended.
Yes.
So what are the physiological aspects for that?
Oh, good point. See, like, if you look to the basic habit of most of the people, 50 to 60% people do exercise in the morning. So if you've taken a dinner at 8 p.m., 8:30 p.m., 7 p.m., 7:30 p.m., then 5 a.m. is something where you are hungry by 10 hours. So that's where you can have hypoglycemia. That's where you can have weakness. That's where you can have faintness and dizziness. So it's 10 hours your body has not received anything. So you have to feed something. It may be a cup of milk, an egg kakro, it may be a badam pista akroot, it may be one banana, it may be one apple, but take something so that you don't encounter hypoglycemia. That's where. Second, science has gone to study a response of your body to exercise. So when you exercise, immediate after exercise, your sugar goes up because that is how body reacts. Glycogen from the liver is broken down and put to blood. Glycogen from the muscle is broken down and put to blood. So if you've taken something, that mechanism has to work less. Otherwise, that mechanism has to work more. So always take something so that you don't risk yourself. There are examples where people have done exercise morning empty stomach and they had hypoglycemia, they had fallen, they had dizziness.
Sir.
Again, don't make it full. It is just some support.
Sir, my question is simple. Whether the speed of the walking is essential to get the benefit, because arthritic patient, obese patient don't walk speedily. So whether it matters?
A good point. See, more the speed you can walk, you get more benefit. Simple. But then again, as I talk to you, adjusting speed as per your fitness of heart, lungs, and bone is very important. So suppose I am very young, I have no disease, I walk at a speed of 7.5 kilometers per hour because I love that and I have trained myself walking, not running, just walking. But then it depends on your fitness. So somebody who has heart attack, somebody who has bone problem can walk 3.5 kilometers per hour. But try to optimize your speed and always take considerations from your doctor also. So maybe somebody who has joint and bone problem, I have seen people who walk at a speed of 2 kilometers per hour who has Parkinsonism. There are senior citizens who have significant Parkinsonism. But that's where even if doing that small amount, even if walking at a speed of 2 kilometers per hour to somebody who is 75 with a lot of Parkinsonism is good. That's where the quality of life improves.
Thank you very much, Dr. Anish Chandarana. So you have, besides your session was so informative, and the questions were taken very nicely, and we have covered a lot of practical aspects. So once again, a very big hand to Dr. Anish Chandarana for this session. And I request the volunteers to give him a memento of the Gujarat Vidyapith, a Gandhian clock. Thank you much. Please, thank you very much once again. And now we will have Dr. Bimal Pal of Gujarat Vidyapith to talk on yoga. I call upon Dr. Bimal Pal to come on the stage. I'd just like to mention that because of a medical emergency, Dr. Samir Dani could not come here. It's a very genuine reason, and that's why we are carrying on with the last session before we go to the conclusion. And a very brief introduction about Dr. Bimal Pal. He studied yoga at the famous Kaivalya Dham in Lonavala, and he is a doctorate in yoga and has total experience of 25 years. And is associated with Yoga Department of Gujarat Vidyapith as an associate professor and head of department. And he has published 9 research papers and 3 books on yoga. And his weekly program comes on DD Girnar on yoga, and which is basically a program which is going to last 50 episodes. And this is going to be a talk on yoga. And before he begins, I request the volunteers to welcome him in the Vidyapith style. He's very much part of Vidyapith, but definitely we have to welcome him. Over to Dr. Bimal Pal. Thank you.
परम आदरणीय डॉक्टर कपाड़िया, गुजरात विद्यापीठ के कुलनायक श्री डॉक्टर अनामिक भाई और मंच पे उपस्थित पूरा भारत के इस क्षेत्र से जुड़े हुए जो डॉक्टर्स, डेलीगेट्स, उन सभी को मेरा प्रणाम। जिस मंच से केवल भारत के ही नहीं, दुनिया के इतने बड़े बड़े विद्वान लोगों ने अपना रिसर्च आधारित वक्तव्य रखा, वहाँ पर मुझे बोलने का एक मौका देने के लिए मैं खुद को बहुत ही गौरवान्वित अनुभव कर रहा हूँ। उसके लिए स्पेशली मैं नहीं चाहता था, लेकिन डॉक्टर कपाड़िया का स्पेशल आग्रह था कि मैं इसके बारे में कुछ कहूँ। मेरा जो विषय है वो है कार्डियोवास्कुलर डिजीज़ के ऊपर योग का कैसे असर हो सकता है उसके ऊपर। अब इसके बारे में मैं महर्षि पतंजलि का दिया गया 2 श्लोक का चर्चा करना चाहता हूँ। आप लोगों ने डॉक्टर मानचंदा को सुना, डॉक्टर सुधीर शाह को सुने आप लोगों ने, और उन्होंने बहुत ही अच्छी तरह से स्ट्रेस का जो रोल है उसके ऊपर फोकस किया। स्ट्रेस को महर्षि पतंजलि योग सूत्र में चित्त विक्षेप नाम देते हैं, चित्त विक्षेप। और उससे बाहर आने के लिए वो कुछ स्पेशलाइज्ड टेक्निक देते हैं, और उस स्ट्रेस से बाहर आने के बाद आपको जो स्थिति प्राप्त होता है उनको वो कहते हैं चित्त प्रसादन, अर्थात चित्त की एक विक्षिप्त अवस्था। और जैसे आपने स्ट्रेस मैनेज कर लिया उसके बाद आपको जो प्राप्त हुआ, जिसको डॉक्टर सुधीर शाह ने कहा, वो ब्लिसफुल स्टेट, चित्त प्रसादन। तो पूरा जो योग की प्रक्रिया है वो वास्तव में चित्त की विक्षिप्त अवस्था से आपको लाकर चित्त प्रसादन की स्थिति में स्थापित करना। अब पूरा जो हमारा ह्यूमन लाइफ है ये दोनों सीमा रेखा के बीच में बंधा हुआ है। यूनिवर्सल हीलिंग प्रोग्राम में जो खास करके शवासन का उपयोग किया जाता है उसके बारे में मैं बताना चाहता हूं कि शवासन जो है वो वास्तव में एक यूनिक योगिक प्रैक्टिसेस है। शवासन केवल आसन नहीं, अगर आप वास्तव में कभी शवासन का प्रयोग किए होंगे तो आपने अनुभव किया होगा कि शवासन आसन भी है, प्राणायाम भी है और मेडिटेशन भी है, तीनों का कॉम्बिनेशन है। जब आप शवासन की शुरू करते हैं कुछ समय के बाद आप प्राणायाम में चले जाते हैं, लेकिन ये प्राणायाम करने के लिए आपको नाक दबाने की जरूरत नहीं पड़ता है। और जब उस श्वास के साथ आप एक रूप हो जाते हैं तब आंजने में आप ऑलरेडी मेडिटेशन स्टेज में चले जाते हैं। ये जो यूनिक एक परिस्थिति का निर्माण होता है, ये महर्षि पतंजलि कह रहे हैं कि ये आपका चित्त विश्रांति कारणम। ट्रेडिशनल टेक्स्ट ये कहते हैं कि शवासन की प्रैक्टिस करने से हमें क्या होता है, चित्त विक्षिप्त था उससे हमारा चित्त का विश्रांति प्राप्त होगा। और अल्टीमेटली महर्षि पतंजलि कहते हैं कि 4 प्रिंसिपल को फॉलो करिए, मैत्री, करुणा, मुदितो, उपेक्षा नाम, पुण्य पुण्य विषयानाम, भावना तच्चित्त प्रसादनम। आपको इतना करना है। लाइफस्टाइल डिसऑर्डर और लाइफस्टाइल को मैनेज करने के लिए बहुत सारे बात हो चुका है। ये जितने सारे लाइफस्टाइल मैनेजमेंट की या बदलने की बात हम कर रहे हैं वो मुख्य रूप में हमारे जो फिजिकल एंटिटी है उसको बदलने की बात है, डाइट को बदलने की बात है, हमारे एनवायरनमेंट को बदलने की बात है, हमारा डेली रूटीन को बदलने की बात है। लेकिन ये सब चीज़ बहुत अच्छा है, लेकिन ये सब चीज़ तब तक हमें असर करने वाला नहीं है जब तक हमारे अंदर से परिवर्तन नहीं होता है। हम कैसे सोचते हैं, हम कैसे देखते हैं, हमारा बिलीफ सिस्टम क्या है, हमारा एटीट्यूड क्या है, हम किस प्रकार से लोगों से पेश आते हैं, ये जो चेंज है लाइफस्टाइल में, जब तक ये चेंज नहीं लाएंगे, जैसे कि डॉक्टर मानचंदा ने कहा कि भाई कोलेस्ट्रॉल देने के बावजूद कुछ रैट्स के अंदर वो एलडीएल डेवलपमेंट नहीं हुआ, ये स्थापित करता है कि अगर उसके अंदर ये चेंज है, ये पॉजिटिव चेंज है, जो खास करके आप जानते हैं कि जनरली हमारे पूरा जो बॉडी केमिस्ट्री है ये ब्रेन से निकलने वाले कुछ स्रावों के ऊपर है। योग कहते हैं कि जैसा मुद्रा ऐसा भाव और जैसी भाव ऐसी स्राव। तो आपकी भावना कैसा है, आपकी भावना अगर हकारात्मक है तो नेचुरली आपके अंदर जो ब्रेन से निकलने वाले वो स्राव है वो भी पॉजिटिव स्राव हो जाता है और वो आपके पूरा बॉडी केमिस्ट्री को चेंज कर देता है। तो इसीलिए ये बदलने के लिए शवासन एक सर्वोत्तम अभ्यास है। लोग कहते हैं कि योग में भयंकर सब अनुशासन है। अगर हम वो सब सुनने जाएंगे, जैसे डॉक्टर कापड़िया बार बार कहते हैं कि इतने डिसिप्लिन, इतनी कठोर कठिन सब व्यवस्था है, तो योग से लोग भाग जाते हैं, सरल नहीं है। लेकिन मैं ये बताना चाहता हूँ कि योग में इतना कठोर कठिन अनुशासन इसीलिए रखा गया है कि ट्रेडिशनल टेक्स्ट में जो योग का वर्णन किया गया है उनका टारगेट है मोक्ष, और हमें यहाँ पर जो योग की प्रयोग करना है उसका टारगेट मोक्ष प्राप्ति नहीं बल्कि हमारे स्वस्थ जीवन प्राप्त करने की लक्ष्य है। इसीलिए उसी चीज को हम बहुत ही सरल रूप में कर सकते हैं और किया जाता है। लोग पूछते हैं कि योग कैसे असर करता है, शवासन कैसे असर करता है। मैं कहता हूं कि दोज हु वांट टू अंडरस्टैंड द प्रोसेस ऑफ योगा बाय इंटेलेक्ट वो बहुत कम प्राप्त करते हैं, और जो इसको विश्वास करते हैं और फॉलो करते हैं वो बहुत ज़्यादा प्राप्त करते हैं। तो शवासन में मैं कहता हूं कि शवासन कैसा होता है, कैसे होता होगा, मैं केवल इतना कहता हूं कि मेलोडी खाओ खुद जान जाओ। आप एक बार पीठ के बल पर लेट जाएं और जो इंस्ट्रक्शन है उसको फॉलो करिए और देखिए आपके अंदर कैसा अद्भुत चमत्कार परिवर्तन आ जाता है, आपके विचारों में परिवर्तन आता है। फिजियोलॉजिकल जो चेंज है, फिजिकल जो चेंज है वो तो होता ही है, लेकिन उसके साथ साथ आपके अंदर एक अद्भुत परिवर्तन आता है, और वो केवल आपको, आपके हृदय को नहीं, आपके कार्डियोवास्कुलर सिस्टम को नहीं, जैसे डॉक्टर कपड़िया बार बार कहते हैं कि आपका जीवन दर्शन को बदल देता है। एक्चुअली शवासन टेक्स्ट में ऐसा कहा गया है कि आप शरीर नहीं हैं, ये अनुभूति कराने वाला अभ्यास है, क्योंकि मरने के बाद शरीर और आत्मा भिन्न हो जाता है। ये शवासन है, तो आपको जिंदा रहते हुए भी मर जाने की स्थिति में पहुंचना है। उस स्थिति में पहुंचने के बाद फिर आपको महसूस होता है कि मैं भले शरीर से जुड़ा हुआ हूं, लेकिन शरीर से मैं कहीं पे अलग भी हूं। ये अनुभव कराने वाले अभ्यास है। लेकिन इसके लिए थोड़ा सा छोटा सा चीज एक करना है। वो क्या है? अब देखिए, डाइट के बारे में बहुत सारे बात हो गया है, और आप लोग जो लोग ऐसे सेमिनार में जाते होंगे, प्रत्येक वर्ष डाइट के ऊपर कुछ कुछ नए नए बात आता रहता है। जैसे कुछ दिन पहले कोलेस्ट्रॉल के ऊपर बात आया तो मैंने डॉक्टर कपारिया को भेजा कि ये तो कोलेस्ट्रॉल तो अभी कोई जवाबदार है ही नहीं हार्ट अटैक के लिए, तो उन्होंने रिस्पॉन्स किया। अभी नए नए डॉक्टर मनचंद्र ने कल इसके बारे में चर्चा किया था। तो क्या है, दो प्रकार की रियलिटी है, एक है फैक्चुअल रियलिटी और एक है एक्चुअल रियलिटी। साइंस जो है वो फैक्चुअल रियलिटी की बात करता है। आज के परिस्थिति में जो डेटा अवेलेबल है उसके ऊपर जो सत्य है उसी को वो कहता है, लेकिन वो एक्चुअल रियलिटी है या नहीं इसका कोई प्रमाण नहीं है। लेकिन योग जो है, ट्रेडिशनल नॉलेज जो है, वो एक्चुअली एक्चुअल रियलिटी की बात करता है, अर्थात इसमें कोई डाउट नहीं। अगर शास्त्र में लिखा हुआ है कि शवासन करने से एक व्यक्ति को ऐसी अवस्था प्राप्ति होती है तो होता ही है, इसमें कहीं पे डाउट की कोई प्रश्न ही नहीं उठता है। साइंटिफिक रिसर्च ये स्थापित करे या ना करे, क्योंकि वो शास्त्र में बताया गया है तो निश्चित रूप में वो होता ही है, क्योंकि वो प्रॉपर अथॉरिटी से एक विशेष परंपरा को फॉलो करते हुए ज्ञान हमारे पास पहुंचे है, इसमें हम डाउट नहीं कर सकते हैं। यूएचपी में जो प्रोग्राम है ये वास्तव में हम उसके लिए बहुत उत्सुक है। हमारे वाइस चांसलर जी ने कुछ समय पहले मुझे ये बताया कि डॉक्टर मंजंदा की हम इसमें सहयोग ले सकते हैं। हमारे गुजरात विद्यापीठ के जो यूएचपी सेंटर है उसमें हम लोग बड़े रिसर्च वर्क करने के लिए जा रहे हैं। हमारे वाइस चांसलर जी उसके लिए बहुत उत्सुक है, सीरियस रिसर्च। और कल डॉक्टर कपड़िया बता रहे थे कि एक व्यक्ति को अगर यूएचपी का सिखा दिया जाए प्रोग्राम तो 1000 व्यक्ति को ट्रेन कर सकता है। मैं ये कहता हूं कि हमारे गुजरात विद्यापीठ के योग विद्या विभाग में लगभग प्रत्येक वर्ष 100 टीचर आते हैं, जिनको योग के साइंटिफिक अप्रोच और उनके साथ साथ उनका इम्प्लीकेशन बहुत ही अच्छी तरह से सिखाया जाता है। अगर डॉक्टर कपड़िया हमारे उस 100 विद्यार्थी को यूएचपी की प्रोग्राम की जो असली चीज है उनको सिखा देते हैं तो वी आर वेरी लकी। तो हमारे ये जो विद्यार्थी है, एक एक विद्यार्थी अगर 1000 विद्यार्थी को इसके ऊपर ट्रेन करना शुरू करे तो मुझे लगता है वो दिन ज़्यादा दूर नहीं है कि ये यूएचपी सभी लोगों का प्रोग्राम हो जाएगा, तब हम कहेंगे कि UHP फॉर ऑल। और एक खास बात वो है कि शवासन की टेक्निक की जो चीज है उसमें कोर जो चीज है दैट इज स्टिमुलेशन एंड रिलैक्सेशन, जो UHP की शवासन में दिया गया है। अगर स्टिमुलेशन के बाद रिलैक्सेशन हो, उसमें रिलैक्स आप बहुत ही अच्छी तरह से, बहुत ही सुंदर ढंग से हो सकते हैं। और केवल रिलैक्स करने की प्रयास करें तो उसमें उतना बेहतर ढंग से नहीं होता है, उसका भी साइंटिफिक डेटा उपलब्ध है। इस प्रोग्राम का और सबसे खासियत और सबसे सिंपल चीज जो है वो है कि इसमें आप कितना कर सकते हैं इसका कोई इंपॉर्टेंस नहीं है। आप जो भी करते हैं उसमें ही आपको बेनिफिट्स मिलता है। क्यों? क्योंकि इसमें आप क्या करते हैं वो इंपॉर्टेंट नहीं है, बल्कि आप कैसे करते हैं वो ज्यादा इंपॉर्टेंट है। दैट मीन्स आप जो भी करते हैं आप उस चीजों के ऊपर फोकस करते हैं, आप उनके साथ जुड़ते हैं, और जैसे आप उसके साथ जुड़ते हैं तो नेचुरली जो केमिकल चेंज, पॉजिटिव केमिकल चेंज आपका शरीर में हो सकता है उसका शुरुआत हो जाता है। मैं और ज़्यादा बात करते ना हुए मैं आप लोगों से रिक्वेस्ट करूंगा कि ये जो योग का प्रोग्राम है जो बहुत सहज है, बहुत सरल है, एकदम सिंपल है, इनको समझने की और जानने की प्रयास करें और उसको जीवन में अपनाएं। इसके ऊपर साइंटिफिक रिसर्च की जो आवश्यकता है उसके ऊपर गुजरात विद्यापीठ सीरियसली सोच रहा है और उसके ऊपर हम काम करेंगे। और एक चीज़ हमें खास ध्यान में रखना पड़ेगा कि जब हम योग की बात करेंगे, योग के बारे में चर्चा करेंगे, मुझे तो बहुत खुशी है कि ऐसे तो अब योग के बारे में बोलने के लिए इतने लार्नेड डॉक्टर्स आज आनंद के साथ खुल के बता रहे हैं, तो हम लोगों का काम तो उन लोगों ने पूरा कर दिया। हम योग के बारे में अब कहे ना कहे, अब योग के प्रति लोगों की आकर्षण ऐसे ही बढ़ने वाले हैं। लेकिन एक चीज हमें ध्यान में रखना पड़ेगा कि योग में, बहुत सीरियसली मैं बताना चाहता हूं, योग में मुझे लगता है, मेरा मत ऐसा है, अकॉर्डिंग टू मी, ऐसा शब्द योग में नहीं होता है। आपका क्या औकात है अकॉर्डिंग टू मी? जहां पर अकॉर्डिंग टू मी है, जहां पर मेरा ऑब्जर्वेशन है, वहां पर रियल नॉलेज होने की चांसेस कम है। आज आपका ऑब्जर्वेशन ये है, कल ऑब्जर्वेशन बदल जाएगा, जो होता है साइंस में। आज डाइट के बारे में ये तेल बताया गया, मैंने 5 साल पहले दूसरे एक तेल के बारे में सुना था कि ये ज्यादा अच्छा है। वाई? वो योग में जो भी बताया गया है शास्त्र में, डॉक्टर कपारिया ने वही चीज किया। उन्होंने मांडुक को कारिका में दिया गया जो एक्सलेंट टेक्निक है योग की, शवासन की टेक्निक, उनमें कोई फेरबदल ना करके उसको आम जनता को बहुत ही सरलता से प्राप्त हो, उसी को ध्यान में रखते उसने रखा। हम उम्मीद करते हैं कि लोगों को ये चीज़ बहुत ही अच्छी तरह से लगेगा। मैं देख रहा हूँ हमारे सेंटर में लोग आ रहे हैं और कर रहे हैं, और एक दिन ये प्रोग्राम ऐसा होगा कि UHP के लिए लोगों को प्रोत्साहित करने की जरूरत नहीं, लोग अपना स्वस्थ जीवन जीने के लिए UHP के अलावा, योग के अलावा इन लोगों के पास और दूसरा कोई रास्ता ही नहीं रहेगा। वो दिन और ज़्यादा दूर नहीं है। इतना बताते हुए आप सबों को एक बार फिर से धन्यवाद देते हुए मैं एक बार फिर से मैं आप लोगों को ऐसे एक अद्भुत सभा हमारे लिए आयोजित करने के लिए और हमें मौका देने के लिए मुझे यहाँ पर बुलाया, उसके लिए एक बार फिर से आप सभी को प्रणाम करते हुए विराम ले रहा हूँ। धन्यवाद।
Thank you, Dr. Vinulpal, for sharing your thoughts on yoga. And now, we have kept this very simple. We are coming to the conclusion part, but it will just be about 5-7 minutes. Acha, Kapadia wants to say something. Yeah. Anyway, we've listened to all the doctors, and that's, I remember of a short story. Motor mechanic, he went to the doctor, and Doctor did some surgery and he charged something, say maybe it was some 70,000 rupees. Here, my car with your engine on. You get the point? The doctors, all of you there. Conference where different thoughts were shared by practitioners based on research, experience, and as I said, it's a holistic conference. So we are not, it's not like a seminar. But then Dr. Kapadia, who had initiated this, he discussed with the experts, and then he decided that we make a resolve. As we said, આપણે resolution કરીએ છીએ, so we call it a resolve, which I will read out. Resolve at the conclusion of Holistic Cardiology Conference 2019 with the theme, The Science and Art of Healing at Gujarat Vidyapith, Ahmedabad. Our younger generation, the young people in India, the future leaders are suffering from alarming rates of cardiovascular disease. Preventing cardiovascular disease is paramount for this generation's health. Dr. Ramesh Kapadia started a program on 2nd October 1991 at Ahmedabad with a lofty goal of evolving simple and effective method of prevention and management of cardiovascular disease. The program has come to be known as the Universal Healing Program, or UHP for short, as it is not only heals heart disease, but heals the whole individual. The essence of UHP has withstood the test of time. It is now tested, proven, and endorsed by the top echelons of Indian and American cardiologists. UHP has embraced the very foundation of Gandhiji's emphasis on simplicity. It is simple, affordable, easy to understand, and thus lends itself to be applied and understood by the grassroots population, which is very important, grassroots population. UHP is a blend of the state-of-the-art medical technology and the age-old practice of savasana, meditation, and Indian yogic science. During savasana, when the practitioner becomes one with his breath, he experiences oneness with the whole creation as the whole creation breathes the same air. The purpose of this conference was to reflect on UHP and the science behind it. An eminent group of thinkers of this subject have added a lot more wisdom to our knowledge base. We fully concur that the wisdom we have accumulated should now be spread and expanded. For all successful initiatives, a key factor for success is always the timing. All of us are convinced that the timing for this initiative is now. It is being launched from an appropriate place, a Gandhian institution dedicated to the welfare of the masses at an appropriate time, that is Gandhi's 150th birth centenary year. Let us resolve to spread awareness and begin reversing this epidemic of cardiac disease among the youth. Thank you. So this is the resolve. And before we proceed to lunch, I'd like to just express our gratitude on behalf of the organizers to so many persons who have helped us. First of all, I'll not take the individual names, so bear with me because paucity of time. But all the experts who delivered their lectures, the diverse fields, the people came from abroad, India, they've done wonderful work. There's so much time and efforts behind this. And the staff of Gujarat Vidyapith, there are so many volunteers around here, Jalpesh Bhai and his team, a big hand for all of them. They've been supporting us through day and night. And the few companies who are major supporters that include Eris, Aprica, Torrent, Opsys Care, and Unison. The event manager, Kumar Bhai, and his team for all the infrastructure, and other individual volunteers. Not forgetting Dr. Dhiren Bhai Shah, who is here for all his support and coordination and contacting the key person, Dhiren Bhai, we can't forget you. And also Samir Dani, unfortunately, as I mentioned, is not here due to a medical emergency. Then Priyanka Patel, who's here, Kapil Pandya, and Vimal Bhai, and of Yogesh Bhai and Prakash Bhai for their support, all the logistics, getting in touch with people. They've done wonderful work. And not forgetting my friend Dhaval Bhai. Where is he? Dhaval Bhai, please come here. So big thank to all of you. And friend, not last and not the least, of course, the press and the electronic media, but the audience for your presence. This hall has been full all the days, yesterday, full day today. So a big applause to all of you. Thank you very much. And we proceed to the lunch area.
And thank you very much to DVS Radia sir for doing a wonderful conducting the conference. I'm thankful to DVS Radia sir.
Abhimal Palma.